Good morning, everybody. A very warm welcome. I would like to do a short introduction and basically also introduce our moderator. First, a few words about the Joep Lange Institute. Some people might have heard of Joep Lange, mostly heard about him through how he died in the MH17 crash. So we started this institute to keep on going with his work, basically. And we are basically, in the end, we are about making health markets work for the poor. And we believe that if we use digital innovation, we actually can achieve this goal more quickly than most of us think. So we have three roles. We try to set an agenda in global health. This is part of that. Then what comes out of it, we try together with our partners, test innovations on the ground for real, and we advocate what works and what doesn't work. So this is what the Joep Lange Institute did. And now a few words about today's topic. Pay for performance, result-based finance. And on the other side, some people call it more versus, but that's not what we try to do today. Intrinsic motivation and behavioral economics. We believe that bringing these worlds together might end in better results for health. And there's a small bridge to the introduction of our next speaker and moderator, Jacques van der Graag. This is basically also his idea. How it started is that we talked and he said, hey Michiel, I read the book of Dan Ariely about motivation. It's called Payoff. And at the same time, I'm driving around in Washington and there are sometimes perceived more doctors working as a taxi driver in the US than there are doctors in Africa. And if you talk to them, they are just literally not motivated to work there. So we believe that it is, again, I say the word believe a lot, but we want to discuss this and also not that what the difference are between the result-based finance and intrinsic motivation, but we hope, and this is the question for today, that we can make it into a better system, reaching better results for health. So again, I mentioned Jacques already, but Jacques is a former, he doesn't like this, but he's a former dean of economics of the University of Amsterdam. He worked for 17 years with the World Bank, or the bank as they say, as a chief economist for human development. He is a co-founder of Amsterdam Institute for International Development, and he is a long-term advisor and friend of the group where Joep Lange Institute belongs to. Jacques, please.
Thank you. Thank you, Michiel. Yes, I'm a former. Welcome, everybody. Glad to see so many people interested in this topic. As Michiel indicated already, we have an exciting day ahead of us, in this group, a morning ahead of us. So I'm not going to waste any more time. I'm going to introduce the three speakers in no particular order. I start with Adam Wagstaff. Those of you who have dangled in health economics should know Adam inside out, I guess. He is currently research manager of the human development team in the World Bank's Development Research Group. And he was an associate editor of the Journal of Health Economics for 20 years. And his long career is now recognized because he is president of the International Health Economics Association, which is a worldwide health economic network. There's more detail on his curriculum in one of the papers that you got. The second, not the second speaker, the second that I'm going to introduce is Damien de Walque, who works in that economic development group as a senior economist. His specialty is human development and public services. It's a little broader than health. He also works and does research in education and the interaction between the two. He also works and manages the impact evaluations that the World Bank does in new health projects. So, country get a health project, would like to put a pay for performance component in there. And then Damien comes running around and said, then I will evaluate whether that works or not. And so between those two, we have really, I would say 99% of the knowledge on pay for performance in this room. Professor Ariely is professor of psychology and behavioral economics at Duke University. He's also chair of the Joep Lange Chair and Fellows program. Now I have to read a sentence that I'm not sure, where's Dan? He's not here. Oh, there. I'm sure it's meant to be nice, but it says he's widely regarded as the world's leading expert on irrational behavior. I think it's meant positively, okay? So, and of course he is a well-known author, best-selling books, gives TED Talks, has a column in Wall Street Journal, and he has dedicated his career to understanding the forces that influence our behavior in order to help people live more sensible lives. In fact, he will tell us a lot, I'm sure, on how that desire to get people more rational, rational, can help, understanding that can help to motivate people in the healthcare sector. I want to invite Adam to the microphone, and I want to invite all of you to turn off your phone. I'm sorry, Damien. Yeah.
So good morning, and thank you very much for coming. While this is going to appear soon, maybe I'll just tell you what I'm going to do. So as Jacques said, the World Bank, there's been a large set of ongoing reforms pushing for performance-based financing. And together with that, there is an effort to evaluate the impact of these reforms. And I'm involved in managing this portfolio of impact evaluation. So I'll briefly show you or explain to you what type of reform those are implemented, then present a little bit the results of first the portfolio and what are its attributes, and then I'll stress that this is still an ongoing set of evaluation, and I'll describe briefly some of the results that we already have, try to summarize that, and then at the end I'll try to go over what is next. So what are what is so far the evidence, and what are the next questions we should ask ourselves. So, and this trust fund is called the Health Results Innovation Trust Fund. And so I'll start by defining what we call RBF, or result-based financing. So a broad definition will say that it's a cash payment or non-monetary transfer made to a national or subnational government, a manager, provider, payer, or consumer of health services after predefined results have been attained and verified. Okay, it's as you say, it's a very broad term, but in practice, it includes various types of intervention that either target beneficiaries, such as conditional cash transfers, providers, for example, what is called performance-based financing, and I guess that's what we are going mainly to talk about today, although sometimes we are going to compare to some of the interventions that incentivize the population, beneficiaries, or sometimes target governments. That's what people call cash on delivery. So let's look at the model for a supply-side performance-based financing, where the incentives are given to the health facilities, which you see here in the middle, okay? So what the performance-based financing does is basically link payment to results. So dollars to immunization, birth, antenatal care. There is a contract. Then the facility within that contract receives more autonomy on how they will achieve the results. Okay, they can decide to invest the money in either staff or equipment or drugs to try to have more antenatal care visits or deliveries at the facility. And there is a system of verification that's ongoing to make sure that the performance, the result indeed have been obtained, and the verification goes through checks with the population. Basically, it goes by calling patients that have been counted and asking, well, we have a patient register that says that you've been for a visit at the hospital in the month of March. Can you confirm that this was correct and that you indeed went to the facility, and which type of service did you receive, etc. Okay, so that's basically the setup. So, and I'll give you one example of, and this setup in practice comes with a list or a menu of prices. Okay, and so I'm giving you some example from one of the first large-scale intervention that was done in the portfolio in Rwanda, where basically there were 14 primary healthcare indicators, and those were such as, for example, 27 cents were paid for each new curative consultation. The delivery at the health center was a little bit less than $4. Completely vaccinated child was $1.82, etc. There were also HIV/AIDS indicators. I'm not going to go over it. It gives you an idea. What I want to point is that using this menu of, or this list of price, you can also do encourage some sort of type of behavior. For example, if you look at the last two, so one client tested for HIV is 92 cents, but one couple tested jointly is 4.59 cents. So it's 4.59 is much more than 2 times 92 cents. So basically, that's the price are set so that we encourage joint testing, which is generally recognized as being better for HIV prevention when husband and wife or the two partners are coming together and get the result of the HIV test together. So just to say that the way you design this price can also help you to push some type of behaviors among patients. Is that for us? Okay. So, as you can see, this is mainly, the prices I've given you are mainly about quantity so far. So of course, if you only incentivize quantity, the risk is that the numbers are going up, but the quality is going down. So we want to prevent that. So there is also a measure of quality of care that is end up giving a score between 0 and 1 and affects the overall payment. So it's sort of your score is going to be a multiplicator multiplied by this quality score. Okay, and I'll come back to the challenges of measuring quality of care. Okay, so that just gives you an idea of where this portfolio of impact evaluation is taking place. You see it's a little bit everywhere, with actually a lot going on in Africa, but not only in Africa, also in middle-income countries such as Argentina. In terms of methods, so we mixed quantitative impact evaluation with qualitative work, and so that gives us mixed methods evaluation. And we always stressed the importance on having a counterfactual. It could be a randomized controlled trial where we have a randomized, where the intervention is randomized, very often at the facility level, sometimes at the health district level. Or when that is not possible because of sample size, because of political reason, we work more with difference in difference. But all this impact evaluation, we stress that it's important to have a well-identified counterfactual. So where are we currently? So there are about 30 impact evaluation in the portfolio. And all of them, and the majority have a quantitative component, but also with mixed methods, and there are 4 that are more qualitative only. So they are all at the stage where the concept node has been finalized and baseline data has been collected, with one exception, the second one in Argentina, that relies entirely on administrative data and civil registration data, so we don't really need a baseline. And we currently have results, that is, the N-line survey has been analyzed for Afghanistan, Argentina, Cameroon, the Democratic Republic of Congo, the state of Karnataka in India, Rwanda, Zambia, and Zimbabwe, and I'm going to focus on that. So we always do a baseline survey, then the intervention goes for 2 or 3 years. The intervention is PBF versus a control group, and sometimes there are other interventions. And so it's a long time, it's a pipeline that moves fairly slowly, because you need to do the concept node, the baseline, etc. So if you ask me, I'm sort of managing this with colleagues. There are some strengths in this portfolio, I think. So that it was mandated by the donor, saying each of these programs needs to come with an impact evaluation. And that gives us a very broad impact evaluation portfolio. And there is really a strong commitment. And so the advantage is that there is no cherry picking. So often what you find is that the most promising projects are going to get an impact evaluation, and the ones that are in a difficult country or not moving so well, there is no desire to do an impact evaluation. That's not happening in this portfolio. The impact evaluation are well funded. There is an effort to measure health outputs and outcomes at the population level. So we almost always have a household survey. And the impact evaluation design is discussed from the beginning with the government counterparts and our colleagues who are designing with the government the project. So one of the risks with this portfolio is that it would be always asking the same question, which would be basically whether and how RBF has an impact. And then the risk is that it's sort of 30 cookie cutter impact evaluations can be useful, but so what over time we've tried to learn more, and we now sort of identify 3 generations of impact evaluation. The first was basically the initial ones, and those are the ones for which I'm more likely to have results at this stage, which is basically, does RBF work? The second generation is testing different variation in RBF and whether they work better than others. Some of the results we have now are already including this. For example, there is a recent one on which I worked in Cameroon, which is trying to see if supervision, because there is reinforced supervision in the RBF through this verification, maybe that would be enough, or whether you need the full PBF package. So it's sort of taking the full PBF package and decomposing it and seeing if some component would be sufficient. And we are moving toward the third generation, where we're trying to compare RBF with other interventions and see also if it interacts well with these other interventions. For example, in Tajikistan, we compare an RBF intervention with a citizen report card intervention, where basically we are eliciting feedback from the population about how they perceive the quality of healthcare, but there is no monetary incentives. And also continuous quality improvement, which is more like a team effort to improve quality of care in the facility. So that's in Tajikistan. I'll show some results from Rwanda, where we have a direct comparison between a supply side incentives and demand side incentives. Okay, so we try to compare this type of intervention, and also there is a stronger focus on quality of care and its measurement, with ongoing studies trying to push the methodological frontier. So I'll talk briefly about Kyrgyzstan, and also a lab in the field experiment in Burkina Faso. So now I'm going to discuss about the impact evaluation for which we have results and which are completed. In Afghanistan, there were 2 studies where there was an NGO implemented pay for performance in primary care centers, an hospital for 5 services, and the quality component was a balanced scorecard, capturing various dimensions of process quality, and it was compared to the statu quo, business as usual. Okay? In Argentina, 2 studies, one for insurance for maternal and child health to uninsured families, and pay for performance for 80 services which were captured from administrative data, and then a second study which we may want to discuss in more detail later in the discussion, where there was a 3-fold temporary increase in the P4P incentives for early initiation of prenatal care, but that was just a temporary increase. In Cameroon, I briefly alluded to that, so there was performance-based financing package for 6 services and a quantity and quality checklist compared to enhanced financing, so more or less the same budget, but not linked to performance. Compared also to additional supervision, but not more money, and then the statu quo, business as usual. In Congo, in the Haut-Katanga province, there was a P4P based on 7 primary services and 3 secondary services, and the comparison group received funding based on staffing levels and composition. 2 studies in Rwanda. The first one provided bonus payment for 14 services. I showed you these 14 services plus the 10 HIV/AIDS services. The second one is this comparison between demand side in-kind incentive for prenatal care utilization given to the woman, and institutional deliveries were incentivized compared to PBF for community health workers, and then a group that was combining both the demand side and the supply side incentives. And a comparison group conducted business as usual. In Zambia, there was a PBF package for 9 services, and again, a balanced scorecard capturing quality of care compared to enhanced financing only, so a group that received more money but not linked to performance, and also there was a pure comparison arm. And then in Zimbabwe, there was contracting of health facilities for 16 services, and again, a balanced scorecard trying to capture quality. User fees were also waived for these services at the primary level of care, and also for 6 referral services at the secondary level. The comparison group was business as usual. So I've briefly described the design of these studies. Now let's look at what are the results in terms of first of health outcomes, then coverage, utilization of services, quality of care, and human resources. So there is so far limited evidence on health outcome, often because it's difficult to get the necessary sample size for that, to measure that with precision. But in Argentina, where we don't really have an issue of sample size because we are using civil registration data, basically the data coming from the birth certificate. There the results show a 19% reduction in the probability of low birth weights. In Rwanda, we find a 69% reduction in wasting among children. So the wasting is having a z-score for weight for age less than 2 standard deviation compared to the normal. And in Zimbabwe, it shows a 36% reduction in severe stunting, which is a z-score for height for age less than 3 standard deviation compared to the norm. So far, so few results in actual health outcomes. And when we find them, except in Argentina, where we have access to a lot of data, it's usually on anthropometrics. When we find them, it's more challenging to find, to measure infant mortality or maternal mortality. In terms of coverage, in most countries, at least some targeted indicators improved, but not all of them. So let's have a look. In Argentina, the first evaluation showed an increase of a little bit less than 2 prenatal care visits and a 24.7 increase in the tetanus vaccine coverage. But we know that there was a negative spillover of 0.8 visits on prenatal care utilization for the non-beneficiary, because the system in Argentina was focused on the people who received the free health insurance, so the poor. And so there might have been an issue of, then with the incentive, the staff is focusing on the beneficiary and the recipient for the free health insurance and less the other patients. In the second impact evaluation, where there was this temporary large increase in the incentive in the Misiones province, we find that even when these incentives are discontinued, there was a sustained 34% increase in the early initiation of postnatal care. So here we find that it's a big question. How long do you need to have this incentive in place? At least in that study, it seems that if you increase it for a temporary period, the effect can be sustained for some time. In Cameroon, we find increases in the coverage of child vaccination and maternal immunization against tetanus, and improvement in the coverage of modern family planning. In Rwanda, in the first study, there was a 23% increase in institutional deliveries and 56% increase in preventive care for young children. In the second study that looking at the PBF for performance-based financing for community health worker, the demand-side incentive increased timely antenatal care and postnatal care, but there was no effect on the supply-side incentive. I'll come back to that. In Zambia, institutional deliveries increased by 13 percentage points, and skilled birth attendance increased by 10 percentage points, but those increases in the PBF group were actually a little bit smaller than the increase in the group that just received additional financing but not linked to performance. The difference was not statistically significant, but that's one example where basically we found that, at least for this indicator, just giving cash with not linked to performance was as effective. The full vaccination in Zambia remained constant in RBF districts, while decreasing in the two other arms. So there was an overall decrease in vaccination rate. So PBF seems to have protected against that. Finally, in Zimbabwe, there was a significant increase in skilled birth attendance, 40.7 percentage point in institutional delivery, and no negative spillovers on the services that were not targeted. That's another question that's often asked. Okay, you have your list of services, but the list does not cover all services. The risk would be that the services not included in the list would be neglected. We don't find that in the Zimbabwe result. Now, in two studies, we find no increase in coverage at all. In Afghanistan, there was no significant change on any of the targeted indicators. What you find in Afghanistan is a huge increase, but both in the control group and the treatment group, probably because they were coming from a very low baseline. In DRC, there was no measurable impact on utilization, despite some evidence that the providers organized more preventive sessions. I might come back to this study in the Okatonga province in Congo that was one of the first PBF system and was not very well implemented or designed. So it's a little bit difficult to draw strong conclusions from that. So let me come back to the second study in Rwanda that I mentioned, where we were comparing incentives on the supply side, which were given to community health workers, and incentive on the demand side, which were given in kind, not in cash, to the mothers. What we find, and then there was a group where there was both demand and supply side incentive, here in green. The control group is in blue, the demand side incentive in red, and the supply side incentive in yellow. What we find is that both for postnatal care and antenatal care, we find a positive and significant impact of the demand side and incentive, but not of the incentives on the supply side. So there might be some question on how well the supply side incentives were designed, but here it's a case where we find that it seems to work better on the demand side. And as you can see, if you look at the green one, basically combining demand and supply side doesn't you buy anything compared to just demand side. Now let's look at the quality of care. Generally, we find improvement, but the evidence is sometimes mixed. In Argentina, the first impact evaluation shows a 74 fall in hospital neonatal mortality, which is quite important. It's actually also a health outcome. But the second impact evaluation did not show improvement in birth outcome. In the Okatanga pilot in Congo, process quality and patient satisfaction did not change. So no impact there. In Rwanda, in the first impact evaluation, there was a 0.16 standard deviation improvement in the quality of prenatal care, but no change in the second impact evaluation for which I just showed the graph. Zambia, completeness of antenatal care counseling improved, but not testing and provision of supplement. But the time spent with the patients increased. In Zimbabwe, we measured 10 to 15 percentage point increase in the availability of equipment and improvements in many process measures for antenatal care, but there was no change. There was no change in non-incentivized services, which actually is a good thing, because I mean, it doesn't mean that they are neglected. In Afghanistan, where there was no improvement in coverage, we find some results, so more complete physical assessment and clinical counseling and more time spent with the clients. And in Cameroon, there is a better availability of necessary equipment for delivery and neonatal care. More qualified workers are present on site. Also important, out-of-pocket expenditure decreased with no negative effects on completeness of ANCU. So in Cameroon, we interpret that as there's actually a reduction in unofficial or under-the-table payment for the patients. So with quality of care, what is really tricky is to measure it, and to measure it well. You can measure the equipment, you can to some extent measure the cleanliness, whether the bathrooms are working, whether the fridge is working, etc. But the quality of the interaction is really challenging to measure. So in this portfolio, we are trying to push towards new methods for measuring quality of care. So in the baseline survey in Kyrgyzstan tested 6 different methods of measuring quality of care. The 6 methods were systematic file reviews, simulations of routine labor and delivery, and postpartum hemorrhage and eclampsia using Mama Natalie. That's what is in the picture here. So it's basically, we were using something that is used for training, which is this sort of anatomical model for simulating deliveries, but instead of using it for training, we were using it as a measure of quality of care. Also using simulation of newborn resuscitation using this same system. I don't know if you can see well the picture, but it's basically a fake, I don't know how to say that properly in English, but it's a fake belly with a baby, and then there is the labor and then the delivery. The other methods tested were simulation of surgical safety checklist use and patient satisfaction exit interview. And the results show that for labor and delivery, simulation using these anatomical models can be better measures of quality of care than direct observation or patient and exit interview. In a lab in the field experiment in Burkina Faso, we designed video vignettes to measure clinical knowledge and incentive needed to serve the poor. So usually what you find very often to test knowledge, not necessarily effort, but knowledge of providers, you The standard method is survey vignettes, which are paper vignettes providing the participants with symptoms and asking them to provide a diagnosis and then treatment, etc. But so in Burkina Faso, we wanted to basically see if in this lab in the field experiment, whether the provider were reacting differently with quote-unquote normal patients and poor patients. And so we thought, well, if it just on the paper vignette you say this patient is poor, this patient is not poor, that's not going to do it. So we used this video where the actress appeared like normal or poor, and she was speaking differently. Okay, and so and then we have used this set of video vignettes in other surveys in Cameroon, in the Republic of Congo, as a measure of knowledge. And so the participants view the video and are asked to select the correct diagnosis, the correct treatment, what would be the follow-up schedule, and what would be the alternate treatment if the first treatment fails. So now I'm moving on the last type of outcomes, which is human resources and especially motivation. There was no impact in Afghanistan and Rwanda. In this study in Congo, in the Haut-Katanga, there was a large decrease in intrinsic motivation. But so I've already said several times that we find sort of not very convincing result from this study in Congo. That's true. But it's probably not very surprising because the formula was poorly designed and also the payments were coming late. And in effect, the people in the intervention group that were subject to PBF ended up receiving 42% less resources compared to the control group, which was not the intention, but in practice, it's what happened. And so it's probably not very surprising that we don't find results in that evaluation that was sort of early in the portfolio. In Cameroon and Zimbabwe, we find mixed evidence. In Cameroon, positive impact on satisfaction with the infrastructure and the availability of the equipment and supplies, but not on intrinsic or extrinsic motivation and job satisfaction. In Zimbabwe, increased of the satisfaction of staff, but lower motivation, which was basically there was one point they were not happy. It was about the size of the incentive and the unit price. I think one of the issues was that the incentive remained the same while the salary increased. So basically the relative power of the incentive was in the end fairly low. In Zambia, it's a significant exception where we measure large increases in health worker satisfaction with their remuneration 8 percentage point increase. So that's a little bit where we are with the evidence so far. I want to stress it's just the result from 7 impact evaluation out of a total that of close to 30 that are still ongoing. So it's the early set of results, and sometimes results coming from evaluating programs that people would acknowledge that they were not always very well designed. So the designing and implementation is also learning from the errors that have been made. But basically, if you ask me, I should also give you some findings from the qualitative studies which took place in Benin, Cameroon, Nigeria, Zambia, and Zimbabwe. That's coming from key informant interviews and client satisfaction surveys. People participating in these surveys find that the facilities are better prepared with the use of PBF funds, that the facilities, because of the autonomy, are doing a better allocation of resources. There is a greater transparency and accountability through the verification visits. And clients report improvement in the perceived quality of care. So, but if you ask me, all this set of evidence, we could discuss for a long time whether the glass is half empty or whether it's half full. I think overall it's a mixed set of results. And I'm not going to try to take a stand on whether it's half full or half empty, but first more look at basically what we could add to make the glass more full. It could be vodka, or it could be more interesting additional question, and I'm happy to receive suggestions. So let me try to take some of the key lessons so far, and then finish with some outstanding questions. So RBF approaches can be cost-effective at increasing utilization and quality of care, but we think more evidence is needed, and also more evidence on the cost-effectiveness. As I said, in several cases, just giving more cash was sometimes giving the same result. RBF programs, as we've seen, for example, in the case of Congo, are not always easy to implement or even understand for the staff. And so health systems need to be ready to absorb such a complex reform. And it's important to be able to do mid-course correction based on learning from these impact evaluations, and also from mistakes in implementation. There's also, and Adam will I think, focus more on that question, but demand and supply side incentives work on different margins and may work best when combined, and the key question would be, where do you put the demand side incentives, where do you put the supply side incentives? And I gave you the example in Rwanda, and Adam will go over the systematic review. I should say also that initially a lot of the PBF reforms were focusing on the supply side, but on the operations side, they realized that, and more and more they're also working on increasing incentives, monetary or not, on the demand side. So the results so far also indicate that the design of the incentive payment should be given a very serious consideration. Uncompensated price reduction can reduce motivation and effort. That was the case in Congo. Team incentives play a positive role, and so far there is not a lot of understanding. There should be more investigation. All these incentives are received at the facility level, but all that money is divided between what stays in the facility, what goes in the pocket of the head of the facility, the doctors, the nurse. There are some instructions, but there are not a lot of studies of what's actually happening and what would be best. Too low of an incentive can lead to an inadequate nudge to provider behavior, but also incentives cannot be unsustainably priced. It is the question, of course, of sustainability of these reforms is important. With this exception, or maybe just flag that if you have in the case of the impact evaluation in Argentina, this temporary increase had sustained effect. So if some of the coverage indicators are high, target or coverage-based performance incentive frameworks might be better suited rather than fee-for-service. In some countries, for some services, we have more than 90% of coverage, so how to design the incentive in such cases. Another alternative to be considered might be flexible fee-based weights that can be modified to indicate current health system priorities. So remember this example from Rwanda, where it was a priority to have joint testing, and so there was a larger incentives for if the couple was coming for joint testing. And so there are many outstanding questions that have to be answered in this portfolio. Some of them are whether RBF programs actually affect maternal and child mortality. What role do RBF programs play in achieving universal health coverage? Another important one I have alluded to is whether these approaches are sustainable. What is the implementation capacity of some country, the financial aspect, the political economy, currently still to a large extent donor funded. Some countries like Zimbabwe, like Burundi, have started to put money from their own government in the incentive schemes, but still that's a big question. Which type of institutional capacity or features are needed for this program to be successful? Also, to what extent do these programs reinforce the institutional capacity of the health system? That's also an important point. And finally, how do these results-based financing programs compare to other interventions, such as, for example, supportive supervision, continuous quality improvement, enhanced financing, and what is the relative value of these results-based financing programs compared to alternative interventions? So basically, if you're a donor, and should you put your money in RBF, in something else, or a combination of RBF and another type of intervention? That's included in this third generation of impact evaluations, but the results are not there yet, and we hope to have, in a few years, interesting results. And I think also another question that we have often sometimes, like I gave you the example of Congo, it was poorly designed and implemented. And so some people tell me, well, you shouldn't include the results because it was just you're evaluating something that was poorly implemented and designed, so it doesn't count. To some extent, that's correct, but also maybe RBF programs are very complex. And they are maybe more or less susceptible to deviations in implementation than alternative programs. So I think we sort of need to ask ourselves whether such a complex reform is always the best fit for a different type of countries and health systems. And I'll finish there, and thank you very much.
Thank you, Damien. Adam, when you make your way to the podium, there's room for one or two clarifying questions. We will have plenty of room for discussion of all the three presentations afterwards. Is there one, two questions that cannot wait? Professor Menno?
Can I start?
Huh?
My question?
Yeah.
Yeah, my name is Menno, and I'd like to ask how results-based financing is different from performance-based. No, sorry, how fee-for-service is different from results-based financing.
So fee-for-service, I would say, is one type of performance-based financing, or can be one component. But I think the example I gave from Rwanda, it's very much like fee-for-service. But then in the overall system, there is more than that. There is the quality correction or quality factor. Sometimes it's not just fee-for-service; it's just reaching a target. So I would say it's broader, but in practice, it's often fee-for-service is an important component.
Yeah, go ahead.
For performance-based financing, short one, yeah. As you mentioned, the verification of achieving a certain result is extremely important because that makes your decision. In your experience comparing all those studies, did you find verification systems that are better than others? And could you comment a bit on that?
Yes, so verification is important because otherwise, you could basically cook the books. But it's also costly. And so people are wondering whether it's worth the money, because, as I said, sometimes just adding cash is enough. So we are trying to move more towards, instead of just the same blanket verification, a certain percentage, more risk-based audits or verification, where we see a sudden increase, there will be more patients that will be verified, etc. So we're trying to be a little bit more flexible or more thinking of reducing basically the cost of verification.
Okay, I got one more. I got one more question here, and then your question has to wait till the other speakers are done.
No, my question is, you referred in the key learnings about that some of the programs might be more flexible, in my opinion, more dynamic in changing incentives during the program. It might mess up your whole impact evaluation, but by the way, but anyway, are you aware of programs which do this in the result-based finance field?
Yes, I don't have a specific example, but yes, I think there have been some cases in the Zimbabwe experiment. I mentioned that the salary increased, and so basically the incentive was not very powerful incentive, and then at the end they just adjusted by increasing. But in the relative prices during the evaluation, I'm not aware, but I think, I mean, we are doing this impact evaluation, but at the end of the day, I mean, this program should live without the IE and the straitjacket of the IE, and I think the relative prices should be flexible, and when there is, like, if you see an important need in the health of the population, there should be the flexibility to increase, for example, the prices or the incentive given for this. Or, for example, switch from supply side to demand side. If you find that supply side is not buying you much, you can try on the demand side or some type of combination.
Okay, thank you. Adam, the floor is yours.
Is it possible to get the... Excellent, thank you. So thank you, Jacques. So Damien gave you a very deep dive into one specific set of projects, namely those financed by the World Bank in the health results health results trust fund. This presentation is broader in a couple of senses. Firstly, as Damien said, there are some demand-side initiatives within the results-based financing portfolio in the World Bank, but they're very small. There's a much broader set of initiatives that the World Bank has been working on demand-side interventions, including health insurance, a reduction of user fees, and perhaps the biggest of all, conditional cash transfers. The other way this presentation is broader is it looks beyond the World Bank. The World Bank isn't the only innovator in results-based financing, whether we're thinking about supply side or demand side. And it's not the only group that's analyzing the results of these interventions. So in some cases, in the particular case of the World Bank, there's one part of the World Bank doing the interventions and working with governments to do the interventions, and there's Damien and his team working to evaluate them. But it's all part of the World Bank. In other cases, there are governments doing interventions and third parties, academics and so on, some of whom are in the room, evaluating the impacts of those programs. So this presentation is an attempt to stand back, not to take an institutional perspective, but to look at both supply side and demand side financial incentives in health and ask, what do we really know about the impacts? And to do this in a very systematic way using meta-analysis. So this is where we're going in this presentation. The presentation is joint work with Damien, Jed Friedman, and Sven Nielsen, who's also in the room. So basically, the background is there's a lot of interest in developing countries and developed countries in incentives targeting providers. In the developing country context, it's mostly the case of moving from low-powered incentives like budgets to more high-powered incentives, which are typically a mix of budgets and pay for performance or budgets and fee for service. In both sets of countries, there's also a lot of interest in incentives, financial incentives directed at healthcare users. Conditional cash transfers, I already mentioned, user fee removals or waivers, vouchers, for example, for maternity care, and expanding health insurance coverage where, for example, the specific services may be those targeted such as maternal and child health services or other interventions. One question we want to ask is, do these incentives work? Do supply-side incentives work? Do demand-side incentives work? Are they actually having the desired effects? So the counterfactual there is no sharp financial incentive, and we want to know, by introducing a sharper financial incentive, do we actually achieve impacts? And we're going to do that both for demand side and supply side. But there's also a relative question that's of interest. So very often these interventions are designed by different parts of an institution, like the World Bank, or different parts of government. So the people who work on conditional cash transfers, for example, in the World Bank, are not typically the same people who work on the performance-based financing interventions. They're different groups, and very often they're different ministries within government. So in practical terms, very often it is a question of either or. It doesn't have to be, but very often it is. So one question that arises is, if you had to pursue one, which would you pursue? Would you go for the demand side, or would you go for the supply side? In principle, you would like to potentially combine both, but as I say, because of fragmentation within institutions and governments, that often doesn't happen. So the relative comparison is also of interest. And part of what we're doing is that. So we're doing essentially a comparative, or what we call MEGA, systematic review and meta-analysis. So we're comparing PBF, or PBF in combination with other things, versus demand-side incentives. We're focusing on maternal and child health interventions, and we're focusing on low and middle income countries. And today is not a final set of results, so we're still actually working through coding some of the studies, and there are different ways one can present the results and analyze the results. So these are tentative results, so this is kind of work in progress. So basically we have here the supply side, performance-based financing interventions. We have a bunch of demand-side interventions we're thinking about. Conditional cash transfers is one category. And then there's a group that we're grouping together that have in common the idea that the scheme in question is trying to reduce the amount that people pay out of pocket. So these we're calling out-of-pocket payment reduction schemes. It could be vouchers, it could be health insurance schemes, or it could just simply be user fee reductions or waiving the user fee for some groups of patients. And what we're trying to do is to combine all of this evidence in a systematic way in this mega analysis, and trying to find all the studies that satisfy certain inclusion criteria that I'll go through in a moment. Just to clarify the difference between the different schemes, because this is something that I think we're going to increasingly try to build on in our work to come, to try to understand differences across studies. So we've got these basically two distinct sort of families of interventions, if you like, or that's how people tend to think of them, potentially misleading in a way for reasons that will become clear in a moment. So we have conditional cash transfers up here, out-of-pocket payment reduction here, and performance-based financing here. As I said, we're grouping these user fee removal or waivers, health insurance and vouchers together here, because what they have in common is that they all reduce the price at the point of use paid by the patient. Do the other schemes reduce the price to the consumer as well? Well, in principle, there's no reason why they should. There are plenty of conditional cash transfer programs around the world that don't. They just leave the price intact, and part of the idea of the scheme is to provide some cash to the individual, part of which may be used to help overcome the existing price. Performance-based financing is a supply-side initiative. There's no reason in principle why that should be accompanied by a reduction in the price. In practice, though, we do see sometimes these schemes reducing the price at the point of use, but there's no reason why they should. Do they increase the income of the consumer? Well, in the case of the conditional cash transfer, yes. If the individual uses the health services or keeps their child in school, they receive an addition to their income. That's the whole point of a conditional cash transfer scheme. None of the other schemes in principle at least, in the pure form, would increase the income of the consumer. So that sort of marks out conditional cash transfers as being different. What about the income of the provider? Well, on the performance-based financing, the answer is obviously yes. That's the whole point of the performance-based financing scheme. It does increase the provider's income, conditional on them achieving certain targets. There is no reason in principle why the others should, but by design, very often they do. So one classic example, for example, is the waiving of user fees. In the early days of those schemes, very often what happened was that facilities were told, you should not charge poor patients for using your facility, their fees should be waived. And the provider used to say, well, who pays for that lost income? And the facility was told, well, you basically don't get any income, extra income for those patients. So in that case, there may well be a reduction in the income of the provider as a result of implementing fee waiver schemes. In the case of health insurance, it depends how it's designed. If it's a sort of money following the patient scheme, it may well be that if I take on additional patients who come through the health insurance program, I get additional income. It may be that it may not be the case. So vouchers, if there is an effect, it's likely to be positive. If you give a maternal voucher to somebody, they basically, that woman takes the voucher to the facility when they give birth, and that voucher is then presented by the facility to the payer, and their income increases by an amount equal to the voucher, potentially at least. Again, it depends a little bit on the design of the schemes. So, I think these are important dimensions to keep in mind when we're thinking about these different programs. So, with any systematic review and meta-analysis, one has to set parameters. So in terms of the interventions, we've already described them. The context is low and middle income countries. The outcomes we're looking at are maternal and child health indicators, and we're looking at a list of Millennium Development Goal indicators, both the official list and the supplementary list that was agreed by various UN agencies at a meeting in Washington in the early 2000s. In practice, we're not presenting results today for all of those. We'd be here all day if we were doing that, and we're going to select just 6 of these today. We also have to be clear about what types of studies we're going to include. And as Damien said, in the World Bank HRITF portfolio, they've been very careful to work with methods that have a very clear counterfactual. In other words, what would have happened in the absence of the program? And that question has to be answered in a credible statistical way. Damien mentioned randomized controlled trials as one approach. Difference in differences is another, where you basically compare the changes before and after between the treatment group and the control group, and sometimes make some attempt to ensure that they are similar at baseline by matching, for example. We also use regression discontinuity, which is useful in some settings, and instrumental variables. So if you've done a study that used any of these methods, you would be in. If you use multiple regression or propensity score matching on cross-section data, or if you looked at interrupted time series looking for a difference before and after, even seeing whether the trend was different before or after, you would be out. And usually at this point there are howls from the audience because there are people who have done these studies and they come up to me afterwards over a coffee and say, why did you exclude my study? It's a really good one. It was published in a top journal. And I say, I'm sorry, we've just got to set the bar somewhere, and this is where we set it. So it does mean that a lot of evidence on these programs gets thrown out. How did we do the review? We went through 7 academic databases. We looked at previous systematic reviews, Google Scholar. We went through websites of think tanks, donors, international agency. We did a call through social media. And then, of course, there's the sort of happenstance discovery. You're sort of sitting on a train and somebody's left a paper on the seat next to them, and you pick it up and you say, wow, this is really interesting. It fits the study perfectly. Usually it's an email from somebody saying, why did you exclude this study? And you look at it carefully and you find actually it fits. So there's a bunch of methods there for going through that. One thing I should emphasize going through this is that when we did our search and the search strings we constructed, we actually did use method as one of the search parameters. So we whittled out studies that, for example, used interrupted time series at that stage. So when I talk about quality in a moment, we're not actually looking at all of the studies in the field. We may have already excluded some when we did the initial search. So here's a slightly more user-friendly version of what's called a Prisma chart in this field. So the search strings we used in these different databases came up with just over 20,000 articles, which were then screened by 2 independent reviewers who had, for a long time, didn't know one another, and we kept talking about he or she, but then letting drop that one of them was called Kevin. And Sven, who was one of the reviewers, has still not yet met Kevin, and they weren't allowed to communicate with one another. So this was a really independent screening of titles and abstracts. Each of them went through 20,000 articles and excluded nearly 19,500 as being inappropriate, so they were very busy. There were 758 articles that were left. The 2 reviewers read the full text of those and excluded 580 of them. And these are the reasons for excluding the articles. Method was one of the big ones, and outcome was another of the big ones. Then we did a little update recently and got 16 additional eligible articles. So we ended up with 207 articles that were potentially relevant, potentially eligible for the qualitative synthesis. So there are 43 PBF articles, nearly 100 CCT articles, 34 insurance, 18 fee reduction, and 15 vouchers. So these are studies that actually passed all the criteria that we set. I should emphasize that because I was quite surprised to see so many PBF studies passing jumping over all our hurdles. This is not necessarily 43 separate PBF schemes. So this includes, for example, 7 or so studies of the Rwanda program that Damien mentioned. And actually another way that this study is broader than what Damien was talking about is the impact evaluations he's talking about are kind of the official World Bank impact evaluations. In addition to the 2 or 3 official World Bank impact evaluations, there are lots of others that have been done of the Rwanda program alone that are by other people. And those feature in these 43 here. So which explains partly why there are so many CCT studies. Lots of these are from Mexico, the Oportunidades and Progresa program. If we focus on these studies that got lost because of methods, this gives you a sense. So the yellow part here, these 88 studies that got dropped because of methods. So a lot of these were just basically cross-sectional comparisons or pre- and post comparisons. These are studies that we didn't include. This gives you a sense of where all of these studies are coming from. So basically, some of these countries have just one program implemented. So the light pink, the light brown, and the light blue are countries where we've had PBF only, CCT only, and out-of-pocket payment reduction only. I should say this is based on the data for 6 key indicators that I'm going to present in a moment. If we were to broaden it out, the map would look somewhat different. You can see some countries that have had 2 types of program implemented, and there are some, the dark red, where you've seen both PBF, conditional cash transfer, and one or other out-of-pocket payment reduction scheme. One thing to be aware of here, and this is where the medics in the audience who do systematic reviews in a much more systematic way than we economists do them, would say, but in this case you're going to be drawing you're going to be drawing inferences based on programs implemented in different countries and different contexts. When we do our randomized control trials and we compare across different interventions, we make sure the context is identical. So in which case the medic might say, well, I'm only going to focus on, for example, India, where I see you've done all 3 types of program, and therefore the context is somewhat similar. If we were to do that in this field, we would have a much, much slimmer database and much fewer questions to answer. This is not how a drug company would go about building evidence on the efficacy of a drug. They would start by saying, we want sites, multiple sites in a handful of countries, so that we can ensure that within the countries we have evidence for settings that are tightly chosen with the same type of hospital and so on, or the same type of primary care facility. And we will only add countries where we feel that the setting, the context is somewhat similar. This is basically working with what we've got. This is not a drug company sitting down and saying, how can we build evidence in a systematic way? So this is a forest plot. And as you know, it's easy to get lost in a forest. So let me talk you through a forest plot, just in case you've never seen one. So in the green up at the top, we've got different CCT programs, and then the blue is different out-of-pocket payment reductions, and then light blue is the different PBF schemes. Against each item is an indication of where the program was and and its name. Some of these may not mean too much to you. Oportunidades was the big Mexico conditional cash transfer program. Juntos, a big program in Peru. Some of these down in PBF are World Bank programs. So for example, the Rwanda one is one that Damien has already talked about. The Katanga is the DRC program he talked about earlier. So some of the World Bank, some of these are World Bank funded projects, but not all, and the same goes for some of these other ones. Some of these were supported by the World Bank, but not most. Then you've got a line which is 0. The number here is the percentage point change, not the percentage change, the percentage point change. And the number here is the result, the effect from the study. So this is basically saying for antenatal care. Those of you who are from South Africa, this is not African National Congress, this is antenatal care. Basically this first line says the Mexico Oportunidades program increased the likelihood of antenatal care, and I'll come back to how we define that in a second, by 1.5 percentage points. But then there's this confidence interval here that's very, very large. So 0 is in the confidence interval, so 1.5 percentage points, but not a significant effect. You can look down and see all of these effect sizes and the confidence interval. With a meta-analysis, you then get an overall effect size, which is this, what is this called? There's a technical term for it, a trapezoid or something, is it? Or a diamond, I guess. Let's use diamond. It's not so technical, but it's something we can all live with. So this diamond gives us the overall effect size, and the tips of the wing tips of the diamond give us the confidence interval. How do we get that overall effect size? Well, it's through a model that is, in this case, a random effects model. There are weights assigned to each study. The larger the study, other things equal, the bigger the weight, and the more precise the estimate, also other things equal, the bigger the weight. So this would mean that, in this particular case, this third one, the JSY program in India, gets a large weight, very, very large sample, and I think the estimate's quite precisely estimated. So the other piece of information, I guess, in all of these studies, a couple of pieces of information you might want to notice is this I-squared, which gives you some sense of the heterogeneity across studies. So you'll see, these jump about quite a bit. There are some places where you see a significant effect, other places you don't. This I-squared, if it's large, means there's quite a lot of heterogeneity across studies in the true effect size. The other number I've added here is a p-value for a test of the hypothesis that the overall effects are different across the different programs. So different between CCT, out-of-pocket payment reduction, and PBF. You'll notice that in all of the slides, this never comes down below 0.1, let alone 0.05. And this reflects in part a lack of power. You know, we don't have that many studies that make it through to the end that have the required indicators and the required numbers. In some of the medical literature, you'll find much larger samples, and you will find some significant differences. But in this particular instance, we don't have that. That's not to say these numbers aren't different. It's just that we can't use, you know, we don't have enough power to conclude that they're statistically different from one another. So what are we taking away from this? Well, we're taking away that PBF in terms of antenatal care doesn't have a significant impact on antenatal care. The other two programs do have a significant impact, so the demand-side interventions come out ahead here. Notice there that there are a couple of low negative effects, in fact, one of which is statistically significant, both from DRC, different programs, one implemented by USAID, the other by the World Bank, well, implemented by the government, but supported by two different agencies. If you eliminate those, things look different. So it goes back to what Damien was saying earlier. You know, do you include everything here, or do you exclude things that are poorly designed? Well, poorly designed, poorly implemented, that's part of the real world. You know, so we've included warts and all here, and you know, I'd need to go through all the CCT programs and whittle out those that were poorly designed and poorly implemented. You know, if I was to do this systematically, I really wouldn't know where to draw the line. So, in the risk of being overly honest, we've included everything here. One thing I should mention here is ANC kind of varies a little bit in terms of the definition across studies, and this is one area where we're a little bit unsure, which is why this slide in particular is not set in stone. Ideally, we would like to have the Millennium Development Goal indicator, which I think is 3 or 4 or more antenatal visits. In some studies, that wasn't reported, and we've gone, in some cases, with whether there was antenatal care, any antenatal care received or not. So a little bit of a mishmash here. If we look at facility deliveries, I won't walk through all of these in turn, but you see here that there is a significant effect for overall for PBF. There's a significant effect for the other two as well, somewhat larger, in fact, for the other two. Maternal tetanus, we've got a significant effect for maternal tetanus for PBF. Also a significant effect, somewhat smaller in the case of CCT. No evidence for maternal tetanus for the user fee reduction programs. Fully immunized, we have no effect, no significant effect for PBF, a significant effect for out-of-pocket payment reduction, but that's just from one study, and a significant effect for CCTs from various studies. Height for age is the only outcome we've looked at so far where we've got a large number of studies showing evidence. And what we see here is just 3 studies for PBF and no significant effect overall. It's only in the Rwanda scheme there was a significant effect. In the case of out-of-pocket payment reduction, so this is a sort of mix of health insurance and user fee removals, no significant effect overall, but we do see a significant effect in the CCT programs. This study pulls all of that information together in one easy-to-read chart, but I wanted to show you the detail of the forest plots so you could get a sense of the reason that the heterogeneity across studies. So basically, the takeaway on our antenatal care is there's no significant effect for PBF. There is for the other two. Maternal tetanus, very similar results for CCT PBF. Facility deliveries, we get positive effects for CCT and for out-of-pocket payment reduction schemes, and also an impact, but a smaller impact for PBF. Postnatal care, significant effect only for CCTs, not for the other two, and a smaller impact for PBF. Full immunization, very large confidence interval for PBF, and it doesn't overall have a significant effect. And for height for age, or HAS, CCT has a significant positive effect, but the other two programs don't. So what are we sort of concluding tentatively about these programs? So first takeaway, I think, is that both supply side and demand side financial incentive schemes have had impacts on at least some MCH indicators. So financial incentives have worked, at least on some indicators, in some places and overall across all the studies. The second point is that demand-side measures have had effects on more indicators than supply-side measures have. So we've got significant effects on maternal tetanus and facility deliveries from PBF. CCT and out-of-pocket payment reductions also achieved effects on those two indicators. PBF has not increased overall antenatal care, postnatal care, or full immunization, while the demand-side interventions have tended to do so. CCTs have also reduced height for age, but PBF so far has not. It's not just the number of indicators that the schemes are impacting, but the sizes of the effects that come out from this meta-analysis. So demand-side measures, for the most part, have had larger effects than the PBF schemes. We don't see significant differences statistically, but that's partly a statistical power issue. What are the caveats we might want to bear in mind here? The effect sizes are small. You know, we are talking 5 percentage points increase, you know, if we're lucky. And that's not, to my mind, a large increase, but I'm not quite sure what large would be. I don't, you know, at least here we're comparing demand and supply side, so we're not just looking at supply side measures and saying, oh, you know, we got statistically significant effects here. We're actually saying how big the effect is and how big it is relative to demand side. But I'm still kind of thinking, well, is this a big number or not? Is 5 percentage points a big number or not? So just to put this in context, there's a study in the BMJ by Esther Duflo and Abhijit Banerjee of a program in India where they encourage women to immunize their children by having this big campaign and offering the women a plate of lentils if they came. That had a percentage point impact of about 40 percentage points. So that's clearly huge. And then they write around saying to the BMJ and the general medical profession, you know, this is really what we're talking about. You know, it doesn't cost very much to do this, and we're achieving huge effects. I'm not sure that's, I mean, they did it, but, you know, is that really the right benchmark to be using? Can you replicate that in other countries? Do we have those sort of percentage point impacts in other programs? I'm not sure. But it's a question that's worth asking, I think. A lot of studies are substandard. We threw out a lot of people's favorite studies because, and we get into trouble for doing that because, you know, people have worked a lot on maternity vouchers, and they say, but all of my life's work has been thrown out. And we say, well, tough, you know, it wasn't using gold standard methods. But it is an issue. I've mentioned a few moments ago the different countries. You know, for someone who's, you know, this certainly, if you were working in the pharmaceutical industry wanting to get your new drug approved, this sort of evidence wouldn't be how you'd go about it. You would go about having sites, similar sites in a smaller group of countries. We're drawing inferences from cross-country differences to some degree here. We also saw, for some indicators, quite a lot of heterogeneity within categories. And I'd remind you about the distinctions I made earlier about whether the price to the consumer was reduced, whether the income of the consumer was increased, and whether the providers income was increased. And I think maybe rather than using the classifications we're focusing on here, we might also want to cut the data differently and classify studies along these three dimensions. And from an economics perspective, perhaps that cut would be more meaningful, and we might get more interesting results out. Not that these were boring, but I hope, but perhaps more meaningfully economic results. And that's it. Thanks.
Thank you, Adam. Same play. When Dan is moving to the podium, we have space for a couple of questions. Clarifying questions. Everything was clear? There's a test at the end of this conference. Yeah, go ahead.
Why do you think insurance didn't have an impact on? Why do you think insurance didn't have an impact on income? I don't think it works. We could have it. Yeah, it does.
So with a conditional cash transfer scheme, the idea is you are actually increasing the income of the person who's a recipient of the transfer. It is explicitly an income transfer. Health insurance is basically reducing the price at the point of use to an individual. So it's not increasing their income per se. But as economists, we all know, I know there are some non-economists in the room, but as economists we all know, of course, that a price change will have a substitution effect and an income effect. It will be as if there was an increase in income, but it doesn't actually constitute an increase in income exactly.
One more, yeah.
Well, this is maybe a long shot, but suppose what you find, is it condition specific? Say you would do this research for chronic diseases like diabetes, and you look at the three determinants and on the relative weight of them. Would it dramatically change, or would you overall get the same balance? But it's taking a long shot now, I know, after 26,000 articles.
So the diabetes would have been kind of thrown out through our search process, so it wouldn't be in those articles probably. And I think if you were to do such a search for low and middle income countries, you would actually find very few studies. If you were to look at the developed world, you would find some, and there are systematic reviews of pay-for-performance schemes, both aimed at hospitals and at general practitioners. And obviously there are interesting studies within that literature that one could talk about. It's not really my field of expertise, but I mean, in my own country, the UK, certainly some of the primary care pay-for-performance indicators have targeted things like diabetes, hypertension, and so on. The scheme, I don't think, was the best designed in the world, partly because a lot of the providers were already operating at the threshold that was set, so they were kind of getting additional income for doing no extra work. But that's a design issue rather than a conceptual problem with the scheme, I think.
But that was exactly my point, that studies in the Western country, they always look only at pay for performance. You look combined at the demand side and supply side, and that is what makes it interesting, because you have the same issues, if I look at the Netherlands, about care avoidance due to income effects, but nobody looks at the supply side. It's always about pay for performance, and that was my question. Suppose you would do this on Western Europe, chronic diseases, with this model, yes, would you really find different effects? But it's a long shot, I know.
All right, we can continue after the third speaker. Dan, the floor is yours.
Very good. So, first of all, when you came to our meeting today, you were given a task. We gave you the task of what could you do with the brick. Right? This is actually a standard creativity task in which you basically get people to say, how many different things can you do with a brick? And we asked you to list as many as you can, and we had 3 payment conditions. Some people were in the zero payment condition. We just say, hey, please tell us how many different things you could do with a brick. Some people were in a €1 per idea condition, right? Every idea is €1. And some people got €20 for as many ideas as you can, right? Now, how many ideas did people produce on average across those three conditions? By the way, we can look at how many ideas people produce and what's the quality of the ideas. We decide not to offend you by telling you about your quality. No, it's a little harder to measure. We'll tell you later about the quality of the ideas, but let's talk about the actual number of ideas. So when we paid people nothing, we got 3.6 ideas per person. What do you think happened when we paid €1 per idea? Up, down, the same, by how much? How many people think it went up? It went down. It went down from 3.6 to 2.8. So this was pay per idea, we got less. What happened when we paid €20? Now realize €20 is not paying per idea, it's just giving you upfront some money for it, right? It creates reciprocity, but it's not dependent on anything. What happened now? Up, down, the same? Went up to 4.4. But by the way, the difference, the small sample and so on, but paying people can actually get performance to go down, or it can get up, and it's not necessarily by what we're paying. When we paid per idea, we got less. When we paid an overall sum that was substantial, people did more, but out of pure generosity. By the way, if you want to get your payment, this study was generously funded by the World Bank. And they ask you to follow the standard process of the World Bank, which is to go on the website, submit your document, get to be approved as a vendor, and then we can talk about the payment. Okay. I want us to think a little bit about pay for performance, not as a holistic thing, but to try and diagnose exactly what problem we're trying to solve and why we think pay for performance would work. And then I want us to think a little bit about medicine and to say what are the characteristics of medicine and under which conditions is pay for performance going to work better and going to work worse. So to start with, I just want to tell you a story. A few years ago, I was invited to visit a country, not the Netherlands, not the US, and I was asked to give them feedback on an incentive programs for teachers. And this was the incentive program that the Ministry of Finance in this country came up with, and they wanted to identify the top 10% teachers in every school and give them a bonus. And the first question I asked these guys, I said, what are the set of underlying assumptions that you're making that come up with a solution, let's identify the top 10% and give them a bonus. And for now, let's forget about how you actually identify those 10%. Let's just assume it's easy to do, or it's possible. Let's just assume that. But every time you offer an incentive program, you have a set of assumptions. So let me ask you, what are the set of assumptions that say the right way to improve education in a school is to identify the top 10% and give them a bonus? What are some of the underlying assumptions?
You want to set the best examples?
Okay, maybe it's by example. What else?
Could be competitive with all of them. Who is going to be the 10%?
Okay, so competition could increase performance. What else? Lack of effort, right? You're basically saying people know what's the right thing to do, they just don't care enough, right? That's the basic assumption, right? Every time you give an incentive, you say people know what's the right thing to do, just don't care enough. What else?
It's the better outcome.
Better than what? Like why? Why would that create a better outcome? Of course, they think it will create, but why? So you say the reasons people are held back, right? Really, when we think about an incentive program, we say what's holding people back? And what they assume was what's holding people back is not lack of knowledge, it's lack of interest. And maybe competition would help. What else?
People don't observe what these teachers are doing, and by measuring it and giving recognition, people will finally see
Okay, so probably you see the top performance, and maybe other people would be inspired. Point 2, yeah? The top 10% of the motivation would increase their motivation. But so you can have two assumptions. You can say this will help the top 10%, or you could say it would help the rest. So another assumption is that more people than the top 10% need to think they could be at the top 10%. Right? Because if only the people in top 10% know they're there, the rest of the people are not going to be incentivized by that. And the teachers are not supposed to learn over time that they can't be in the top 10%, right? If you think that everybody will think in the beginning, 50% in the beginning think they could be in the top 10% and will compete, over time they'll learn that they're not in the top 10%, people should not learn to do this. And then I asked them, how many of those assumptions do we have any evidence for? Right? You know, one of the best exercises ever to increase quality of education in schools was to take the top teachers and give them time to teach the not-so-good teachers. Now, that one empirically worked. Now, why does it work? Because what's stopping teachers is often not caring enough, right? It's just not knowing what to do. Teaching is actually a very, very tough profession, right? The feedback cycle is very tough, right? You could teach some kids something at some point and you never know what happened to them. I wrote a few years ago to my high school teacher to tell her, you know, I didn't end up in jail. You know, it was, you know, when you think about it, like you have difficult kids, you never know what's going on with them, what works, what doesn't work. And what the study showed is that one of the main barriers is lack of knowledge. Right? Now, what would happen for sure if you took the top 10% of the teachers and gave them an incentive? That they will stop helping anybody else. Right? So the point I want to make is that when we come to think about incentives, it's easy to think in a very general way, like it's a hammer. Just pay people and everything would work. But the reality is that what we need to do is to take a layer deeper and say, what is slowing people down? What is stopping them? What are the barriers? Are they really just not interested? Don't they know? They haven't figured out how to put the effort. They don't have the resources. What exactly is going on? And without a deep identification of what's going on, we're just going to waste money. Right? It's not going to work out. And the second thing, of course, is to realize that we call lots of things medicine, but they're very, very different things. Right? We have healthcare professionals and physicians. We have difficult procedures and easy procedures. We have things where the outcome that we want is exactly what people are doing. We have things that we could only measure years later and so on. So things change dramatically. So we need to understand that we need to understand the root cause, and we need to understand that medicine is not really one thing. Okay, so first of all, let's ask the question of why do we want to pay people for doing X, and whatever X is, right? Why do we want to pay people by performance or by procedure and so on, right? In the same way that we can ask the same questions about why do we want to pay teachers? And we have to admit that we're doing it because we say, left to their own accord, people are not interested enough, right? We're assuming that we need to do this because people are not sufficiently interested in what they're doing by themselves, and then we need to add an incentive. The other thing we're assuming is that keeping their job is not a sufficient motivation, right? Let's remember that it's not as people have no incentives, right? If you go to a physician or a nurse practitioner, whatever it is, it's not as if they have no incentive right now. The incentive right now is they get their livelihood paid for by doing their profession. So we're saying two things. We're saying that's not an incentive enough. They're not sufficiently interested. And we need to add something external for that. Okay. So that's the first thing. And now I want us to talk a little bit about characteristics of the medical system. And all the characteristics I will mention are things that, if they're true, or in the cases when they're true, they would make pay for performance less effective. right? And of course, as we said, there's lots of different types of medical systems and so on, so they're not always applying, but let's think about it. So the first thing is to realize how difficult is it to directly and accurately evaluate the quality of performance, right? Every time that this is easy to do, pay for performance is a better system. Every time it's harder to do, pay for performance is not so good. And for multiple reasons, not just because we don't know how to reward people, also because it's very confusing. Let me give you an example. Imagine that you're in charge of figuring out where to open a restaurant. And you work at the company and you do all this analysis, and you decide to open a restaurant in the Gulf of Mexico. And you open the restaurant, and a week later, BP decides to spill a lot of oil just next to your restaurant, and your restaurant goes under. Did you make a good decision or a bad decision? The moment the world has noise in it, the relationship between what you do and what the outcome is has lots of other intervening variables, it's also very confusing. You can have a good behavior one day, and the world can punish you the next day, and under those conditions, it becomes incredibly demotivating. Another example from health, people expect that if you eat well for a day, you eat salad and go for a run, you should lose weight tomorrow. And if you do it for 2 straight days, you should certainly lose weight. Turns out the body doesn't react this way. You can have a whole day of Netflix and pizza, and you would lose weight. You can have a day of running and salad, and you'll gain weight. There's lots of noise in the system, and every time there's noise in the system, people get confused, right? Now, if you add that confusion plus reward, some people would get money for being lazy. Sometimes they will work extra hard and make the right decision. They would lose money. That's not a good system. So the first thing we need to recognize is what is the relationship between what a person does and what the outcome is. The more tightly linked they are, we are more in a condition for pay for performance. The worse linked they are directly, not statistically, but almost like deterministically, the better we are. And in most population health, we're not like that. So we are certainly that in some of the prenatal care. Give food to the kids, easy to do. Cholesterol reduction, much more difficult. Okay, so that's point number one. I mentioned this one already. Okay. Sometimes some aspects are easier to measure, and some aspects are more difficult to measure. For example, how do we measure the effect that physicians have on patients' motivation? In the US, there's lots of smoking cessation programs where physicians are basically trying to get patients to stop smoking. And what is very easy to measure is whether they took a pamphlet and gave it to a patient. And guess what? They all give pamphlets to patients. How effective do you think giving pamphlets is? Zero effect. Having a discussion with a patient about it, very difficult to do, very difficult to measure, basically doesn't happen. So we have to recognize that some things are easy to measure, and whenever we make an incentive system, those are the things that will happen, and the things that are more difficult will not necessarily happen. Another important point is to think about short-term versus long-term. There were a couple of very nice studies that show that if you pay physicians to reduce cholesterol, cholesterol goes down without healthcare going up. Why? It's really easy to reduce cholesterol, right? Just give people pills. Cholesterol goes down. Is it the right way for the right people? Not necessarily. Now, many times what happens is that the short-term incentive, the thing that we're seeing, is easy to focus on. The things that we really want are very, very tough. And by the way, this is not to say that physicians are not kind, wonderful people. It's basically saying that whenever you measure something and you bring it to focus, we become extra excited with that. There was one study in which they tried to figure out what is the healthy and non-healthy level of hemoglobin, right? Like how much somebody is under surgery, they have a reduction in red blood cells, what level is healthy and not healthy. And they got physicians to agree that they will not give blood unless it's below 7. Guess what? Most of the physicians in the study who agreed not to do it failed. Why? Because they had a patient, and the patient was getting white, they were pale, their oxygen level was going down, and the physician said, I know I agree not to give this patient anything until their hemoglobin goes down, but think about the treatment. You give people blood, their quality goes up immediately. It's just very tempting to do. So many times what we have is we have short-term measurement and long-term measurement. They are just not the same thing. And by creating pay for performance, we could get people to focus on the short-term rather than the long-term. The next one is, of course, a problem that has to do much more with the Western systems than with systems in Africa, but it's still a question of what interest are we serving and who exactly is serving what interest. If you think about the health system, especially in the US, it's a tanglement of conflicts of interest. You have the patient, you have the doctor, you have the hospital, you have the HMO, you have the employer. They all have interest, not to mention you have drug companies and device companies, and they all want very, very different things. And they all have their own incentives to put in the service of getting their interest to be activated. Now, one thing to realize about conflicts of interest is that conflicts of interest is not about bad people, it's about good people having conflicts of interest. The nice thing about conflicts of interest is that people are really cheap. One of the best investments you can make in the US economy is to lobby. Why? I mean, this is even before Trump. But why is lobbying so expensive? Because it turns out people are cheap. You can buy somebody a beer and a sandwich, and from that perspective, from that point on, they start looking at life from your perspective. Right? And it's not because they're bad people, they're wonderful people, but they start liking you a bit more and looking at life from your perspective. And of course, it's a wonderful thing, right? This is how we make friends and so on. But once you put it with financial interest, things become very, very difficult. So what do you do with a system that has so many conflicts of interest, right? So many conflicts of interest. And the moment we start adding payment, we're also changing conflicts of interest. We have to recognize that. Okay. So we said lots of room for that. Tremendous asymmetry from information. Of course, medicine is all about asymmetry of information. And as we move forward, as medicine is becoming more complex, more interesting, more advanced, asymmetry of information increases it. Lots of room for gaming the system, right? We have to recognize that the moment we put pay for performance, we're also getting some opportunities for people to game the system. It's impossible. What was the quote you gave about there's never a way to create a perfect payment system. Whatever payment system you create would always have downsides. Okay. Another thing that is happening a lot in the US now is capacity for selection process. So imagine I'm a hospital, and I get rewarded by the percentage of people who are released from hospital and don't die for a month. That's not exactly how it works, but let's assume that was the system. What's the easiest way for me to make sure that people are not dying in my hospital or shortly after? Sorry? That's right. Send the real sick people to other hospitals, right? And we see that happening in the US. We saw it a lot happening in the US with what's called the No Child Left Behind policy. So Bush created a program called No Child Left Behind policy, and they defined a minority by having 19 kids in a school from a particular minority, and if that minority failed, the whole school failed. So what did school do? They would not accept the 20th kid as a minority, because 19 kids were not yet a minority, So if the 20th kid wants to go to that school, they wouldn't do it. They would ship them like 2 hours to a different school on a bus, just not to be a part of that. So we have to remember that when it comes to performance on health, the entity itself can do all kinds of things that it's in the service of the measurement rather the outcome by using self-selection. And of course, in medicine, there's lots of options for self-selection. High-stress environment. We have to agree that the medical system is already high-stress environment. How much do we want to create a payment system that adds to that stress? Right? How much do you want, and this is actually a kind of an interesting thing. If you think about any kind of bonuses or pay for performance, the basic thought is the person is not sufficiently interested in this, but by adding money and get them to think about money, they will become somehow more interested. So you're basically saying, I want you to occupy part of your brain by thinking about money all the time, and by occupying some of your brain thinking about money all the time, somehow you would be able to perform better. And that might be a really good assumption for mechanical skills. Jumping, layering bricks, something simple. But if you have a skill that we want people to use all their brain and creativity and ability, how much do we want people to dedicate even 5, 10, or 20% of their brain to think about how much money they're making right now? But if we're creating those systems, that's what we're creating. So high stress plus high stress environment, people already think about, have a challenge with capacity. Adding more to it has to be negative. Averages. When I used to teach statistics, I used to tell the students that on average, Americans have slightly less than 1 testicle. And it's true, but it's not a good description of anyone. And this is actually a really, I think, important point on whenever we create a pay system, we're basically getting people to do what's good for the average, right? We could say, this is what is good by the average physician for the average patient in the average setup, and this is how the system works out. What happened if the variance of what's the right thing to do is just very, very high? Imagine we even talk about something simple like diabetes. Some patients might be better off with changing their diet. Some might be better off with changing exercise. Some might be better off by changing the medication regime, right? What is the process? If we just pay physician by prescribing medications, for example, or just pay them to get people to change their nutrition, it might not be the right combination for any particular patient. So the first point of what I wanted to say is that the medical system, I think, or medical systems, for me, don't have the right characteristics for pay for performance. I think pay for performance is really good for things that are incredibly simple, right? If I wanted to pay you for how many miles you run today, I think that's doable. If I want to pay you for how many bricks you put, I think that's doable. Once you basically say we have a system that's people to do different things for different people, medicine, I think, is more like an R&D process, where you need to kind of figure out what is the right thing to do for each patient, and then figure out how to do that. And we don't have a good payment system for those things. Now, so what can we do? What can we do? Okay, so I think the answers for me come from 2 sources. The first one is to think about intrinsic versus extrinsic motivation, right? And as you saw in the results, you all gave us lots of ideas for what to do with bricks for no other incentive, right? Think about your own lives. How many of you work hard because your pride is connected to it, and your interests are connected to it, and you get rewards from society, and you might advance in your career, but it's not a pay-for-performance approach. By the way, how many of you would want your company to add a pay-for-performance component to your own jobs? When you think about it, it's kind of interesting that we say, oh, other people probably want that because other people are just motivated by money, but we are interested in all kinds of other things, right? We want to have an impact. We want to understand what to do. We have our this general. And what we find is that sometimes adding payment systems can actually decrease intrinsic motivation. Very simple example. Imagine I asked you for a favor. I said, you know, I have a flat tire on my car. Would you help me change the tire on my car? And you can think to yourself, how likely are you to help me? Or in another setup, I would say, you know, I have a flat tire on my car. I'll give you €3. Would you help me change the tire on my car? How would you react to the second case? Would you say, gee, I get to help Dan plus I get €3? No. Right? You would say, oh, €3. It's a job. I don't work for €3. Give me 300, we can have a discussion, but for 3, I don't work. And actually what we often find is that adding incentives decrease intrinsic motivation. And I can tell you about lots of studies we've done it, low income, high income, across the board. But the moment you give people a pay for performance, you're basically telling people that you don't trust them. Right? It's not, you actually don't trust them, but you're also telling them that you don't trust them. And when you don't trust them, something about intrinsic motivation goes away. So we can have a whole bucket that we can call pay for performance. But one other approach is to say, you know what? We don't think we could ever get to an optimal system. Should we work on intrinsic motivation instead of that? Right? Not easy to do. And I'm sure there'll be some cases in which pay for performance would be better. But as a general bucket, I think it's very useful to think about it. Are we undermining motivation with pay for performance? And could we take the same incentives, the same amount of money, and build intrinsic motivation? And by the way, it doesn't mean not paying people, right? Direct cash transfers, as was mentioned, is a way to say, we trust you, do with the money the best thing you can, right? Direct cash transfer can be on the intrinsic motivation part. They don't undermine it. So that's one direction. The other big point is to think about complete versus incomplete contracts, right? So we have these kind of two very distinct notions in economics. And complete contract is the place where we could write everything down. Here is what you'll do, and here is what we'll do, and so on. Incomplete contract is something like marriage. Like, think about the contract in marriage. You say, for better and worse until death do us part, or whatever your version of this is. What a strange contract. Like, what happens on a daily basis? Who takes the trash? How many times a week do you have sex? You know, what's the details? No lawyer would ever let you write that contract. But it's on purpose. It's on purpose. Why? Because we don't want a tit-for-tat relationship. We want to say these contracts need to encompass lots of different things. And we actually can't enumerate them. Because the worst thing that having a complete contract is having a partial complete contract. Because every time you have a complete contract, there's also things that you leave out of it. And the things that you leave out of it are not just out of it, they're explicitly out of this. So now think about the role of a physician. You see a patient. And let's say the complete contract says you have to spend 12 minutes with them, and you have to ask them whether they have a question for you, and you have to give them a pamphlet against smoking. You will do exactly those things. What about all the things that have not been written? You see the person is extra stressed, you see they have something else, they are not part of your contract, you're less likely to do them than if you didn't have it. So in the same way that we think about intrinsic and extrinsic motivation, I think we also need to think about incomplete versus complete contract. The oath of physicians is very much an incomplete contract, right? But just the day-to-day process is incredibly about complete contract. This is, by the way, one of the things that in the US we're really ruining. I wrote a little piece for the Mayo Clinic Journal about physician stress. In the US, about 400 physicians kill themselves every year. It's one of the professions that, in terms of quality of life, is decreasing dramatically over time, much more than other profession. And part of the reason is physicians join the profession to heal people. Right? That's what they join, right? Nobody goes to medical school because they say, I love paperwork. Right? But then at the end of the day, what they have to do is submit paperwork. Right? And think about this contrast. On one hand, we give physicians scalpels and operating room, and they let us cut into us. On the other hand, if they want to prescribe a particular medication, we say, no, you can't prescribe that. My own physician prescribed to me a medication a month ago, and the insurance decided to decline it. They didn't think this was right. Now, the same person can make a decision about what surgery to do. That's fine. But with medication to write, no, and how much paperwork is involved is incredible. So what we're doing is that we are creating this tremendous lack of trust, lack of autonomy, and really tremendous amount of paperwork and bureaucracy. What is the cost? What is the cost of that? And what is the role that healthcare providers have in their own mind as we make the system more complex in this way? Okay. So I said this already, so let me just summarize. If you think about professions that would have the right ingredients for pay for performance, it needs to be something simple with high quality, immediate output that we could all measure, we could all agree on, that the person themselves know what's the right thing to do. And now the question is, how many of those are in medicine, in the practice of medicine? I personally think that very few. Very few. Now, there might be some areas of medicine that are better, bless you. For example, if we need to purify water, that fits. If we need women in prenatal care to take a particular supplement, that's right. But there's so many areas in medicine in which none of those conditions are right. So now the question is the following. If we think those conditions are not right, what do we try to do? Do we try to force that system anyway? Or do we try to move to another system? Do we try to move to a system of intrinsic motivation rather than extrinsic? And do we try to even make contracts more incomplete rather than complete? Now, we haven't done that experiment, but that I think is the right direction to try. Okay, that's it for me.
Can you get somebody to get Thanks very much, Dan. Again, same format. Any clarifying questions while the chairs are being put on the stage for the discussion? Anyone? Oh, go ahead.
So I have a question about the people involved in setting these incentives. Should the healthcare worker themselves or the patient have a role in it?
Yeah. So the first point I was trying to make is that in order to set the right incentives, we need to know what's slowing people down. Right? And I think the workers themselves are probably the best people to tell you where the barriers are for good performance. So that's one. But the question of whether the workers themselves are best suited to set up their incentives? I think the answer is no, and I'll give you one example. Imagine you worked for me, and I was going to give you $1,000, 1,000 euros as a bonus. And I said there's two ways for me to give you this money. I can just give it to you in cash, or I can send you on a weekend to Belgium. Right? It would cost me $1,000, the same thing. You might say, give you the cash, you buy an iPad, and you'll go for a cheaper vacation. Right? You might be able to do more meaningful, you might be able to use your cash more meaningfully. But remember, my question is not what you want to maximize your financial well-being. My question is what would get you to be the best employee possible, right? So now what I could do is I could say which one would get you to be more loyal. And it turns out that sending you to Belgium for a weekend, I haven't tried that one, but we've tried lots of other things like that. Sending you to Belgium for a weekend is much more likely that if in 2 weeks I'll need you to stay over late or do something extra, you'll be more likely to do it. So we have some good intuitions about how we create loyalty with people and friends, right? Like if I invited you to come to dinner to my house and you were going to spend 30 euros on a bottle of wine, you wouldn't show up and say, you know what, Dan, I don't know what wine you like. Red, white, European, American. Here is 25 euros. Go ahead and buy yourself the best wine possible. You would understand in the social domain that this would not help our relationship at all, right? And my care about you, my interest in you is actually going to decrease rather than increase. Now, the same intuitions actually are true for the workplace as well. If you ask, what can you do to increase your commitment and interest and motivation, they're not very, very different, but people don't have the same intuitions about this. So I think people would be really good at identifying what's not working well, but we're not that good in actually identifying what would motivate us.
All right. Well, we unrobot this robot. Is another? Yeah, Eddie.
I think most people studying pay for performance are very much aware that that's a very imperfect way of trying to achieve certain things. But I was anxiously awaiting your last sentence or your last slides to see what the alternative is and how you could increase intrinsic motivation. Because so far we've tried the Hippocratic Oath and it works to some extent, but not perfectly, as has been shown. So very curious to hear how you could get this intrinsic motivation increased.
So the first comment to realize is that when we do pay for performance evaluations, we rarely study like what's in the control condition. It's usually nothing, or sometimes it's supply versus demand side. There are very few cases in which we try things that are completely in the social realm. We did one study, not in a medical setup, but we did one study with Intel, the chip manufacturer. These were people making chips, right? And you can measure how many chips they make. It's a really good thing. And we tried four things. Some people got paid a bonus if they reach a certain level. Some people got a voucher for pizza. Some people got nothing. And some people got a text message from the boss saying, nice job. So think about those four conditions. People show up, a quarter of the people are told nothing, financial, pizza, text from the boss. It turns out that on that day, the control condition did the worst, the other three conditions did better. Money, pizza, text. Money was slightly worse than the other ones. Okay. What happened the next day? This was on the sequence of long time. The next day, there was no bonus. There was no target, right? It was basically measuring goodwill, right? Because you can't always measure it. And even if you're measuring something, there are other things you're not measuring. So we said, okay, so we gave people incentives one day. What happens the next day? No incentive. It's a pure measure of goodwill. The money condition went up on the first day. On the next day, it went down below the control condition. And if you look at an average week, by paying people bonuses, Intel lost 5% of productivity. By giving people bonuses, they lost 5% compared to doing nothing. Okay. What happened with the complement condition? Went up slightly more than the money condition, and went slowly down over the next few days, but was always better. So here's an experiment, one experiment, different domain, that says complement was as effective as the reward, slightly more effective as the reward when it was given, but in terms of goodwill, it created much more ongoing goodwill than the financial one, and the financial one backfired. And by the way, pizza was between them, right? So there are, I think trying to understand those things is incredibly important. We're making steps, but the first step would be to include those things in some of the experiments.
All right, thanks. I would like to invite the speakers to climb on those chairs here. Let me make an in-between remark. One of the motivations to have this meeting was about 2 years ago, when we had a workshop in Kwara State, where all representatives of every state in Nigeria on the health sector came together to listen to some of our presentations on the impact evaluation of the Kwara State Health Insurance Program that was implemented by Farm Access. It was a fairly upbeat meeting for 2 days, large group, like 250 people stayed for 2 days. And basically, it was a very positive event. I remember vividly, though, that I mean, let me tell you why it was positive. There was more patients were going to the doctors. The doctors made more money from the prepaid health insurance premiums. They could hire more support and more, drugs or whatever they needed, and expand their supply. But that is all as if they were a private clinic. So there, I would say the incentives were nicely aligned. There was one doctor who got up, who was the director of a public hospital. And he said, yeah, well, this is all true, and indeed we have more patients coming, and it's busier. I said, but my people don't see that extra money. And at Friday at 5, they say, we work from 9 to 5, it's Friday, we go home. And whether there are, pregnant women on the steps of the hospital coming to deliver the baby, this director of the hospital has to say, sorry, we're closed, come back on Monday. So somehow, and Michiel also already mentioned the cab drivers with a medical degree in New York City. Everybody who is in the development field knows that demotivation in healthcare, but also in education, leads to people dropping out of the sector, absenteeism, poor performance. And these are people who have spent a big chunk of their life trying to learn those skills, who have spent a big chunk of money to get those degrees. So my observation is that we may not be very good yet in motivating people to do things more and better, but boy, are we good at demotivating people to drop out of the sector. With this happy introduction, I had some prepared questions.
Can I make one comment about this? There's a big difference between paying and paying for performance, right? And this idea that people have a job and the job pays them a living wage and they get to keep their job, that's a wonderful set of motivations, and we need to understand it. Now, if people can't make ends meet, that's a different story, but it's a separate issue. Basic salary is a separate issue from pay for performance. And if we want to pay people more, we can figure out how to do it. It doesn't mean pay for performance.
Sure. If I can just, that's certainly true. But in most of the schemes that we've seen, it's a combination of both. People have a salary. Mm-hmm. In some countries, indeed, that is very low. But then the pay for performance comes as an extra bonus, but there is usually the combination. So none of the schemes that we've seen replace the salary with.
But you can, let me give you an example. This is a study we did in a call center. Big call center, again, good place to measure productivity and so on. And we looked at the data, these people get 30% of their salaries can be a bonus. Up to 30% per week is a bonus. And we looked at the data, and we saw that it's the same people who get bonuses every week. The same people get bonuses every week. And we asked the question, why? And you can come up with all kinds of hypotheses. Nepotism, tricking the system, good performance, whatever it is. We convinced that hotel chain to give us the data every Friday for us to decide who gets the bonuses and for them to distribute those bonuses on Monday. By the way, think about the trust of that CEO to give me that power for 6 months. And they asked us to send some students to their office to tell the employees that we're going to decide the bonuses so they don't blame the company. We didn't say we're an academic institution. We said we're a consulting company, and we're going to decide on their bonuses for 6 months. And for 6 months, we would get the data on Friday. We would choose the algorithms, and we would announce the bonuses Monday morning. And what kind of algorithms do you think we tried? What would you try? Random, that's right. You try random. You don't tell people it's random. But if you have a particular theory, like give the top employees bonus but not the bottom, you never know what would happen if you did the opposite. So one of the nice things about random incentives is you get all the possible combinations, and you can later analyze what works and what doesn't work. So one analysis we did was to ask the question of when does the company get higher return for performance, higher return on bonuses? When they give bonuses to the top employees or the bottom? Just imagine the top and the bottom half. Should you give bonuses to the top employees or the bottom employees? What do you think? Turns out the bottom is better. From a return on investment. Why? The top employees are already good. They're already good. Like, you know, if you're a good singer, let's say you're a good singer, and I pay you a little bit less, would you start singing out of key? No. Some people just know what they're doing, they love to do it well, and that's what they do. And actually, those people did not go down in performance. They found a way to work in an efficient way, and they were insensitive to payment. The people at the bottom are the people that could work harder, they could try harder, and they actually managed to work harder. Our recommendation, just to be clear to the company, was not to keep on paying randomly, and the recommendation was not to pay the bottom employees more. The recommendation was to say, take the top employees who seem quality insensitive to payment because they're at the top of their game. There's no place up for those people, and they don't want to go down. Give them a different title and give them a higher fixed salary, right? Why put 30% of their income at risk when they can't control their quality, and then take the bottom people, the people who can actually try harder, the people who will be influenced by incentive, and give them a different title and different name and focus the bonus there. But this again goes back to the question of, you know, what are our assumptions going into this thing, right? The top performers in this company were doing their best already. Why not just put them out of that system?
Okay, I think, no.
Jacques, could I just jump in? So,
well,
just to link
what you
were saying earlier and what Dan was saying just now and what I was saying earlier about the UK. So, I mean, it seems to me what you're consistent with what you're saying there, Dan, is that there are some settings or some groups of people where linking their pay to their performance is probably not a great idea. You know, they're doing great anyway. That was true, for example, in the UK's general practitioner pay for performance scheme, where there was a bunch of general practitioners who were doing great already. All the scheme did was just give them more money, and some of them didn't even want the extra money. They were living a lifestyle that they were quite happy with. Your point, Jacques, is that there are people in developing countries where the salary is so low that actually you're not making ends meet. And actually then this distinction that is made my wife is Italian, and in Italian you have a distinction between, in English we say a job. In Italian they make a distinction between a job and a position. Everybody wants a position. A position is a salary, and it's a place where if you like you go to work. but you get the salary anyway, if you're lucky. The job is something you don't really want because that requires effort. So in that particular case, in the developing country case where you talk about absenteeism, people have a position. They're not showing up to work very often, and when they are showing up, they're not exerting much effort. We know that in terms of the studies that look at fake patients and so on. They're not asking many questions, they're not reaching the correct diagnosis in a lot of the time. In that setting, linking pay to showing up to work is for sure a good idea. Linking pay to actually what you're doing on the job is also, I think, a good idea. That's two extremes. But I think what we're saying is there's some point between those two extremes where you start to worry about the usefulness of pay for performance at the margin. But I think it's a long way from the case where you haven't got enough money to live on by simply relying on your salary. I think there are plenty of, I would say, most low-income countries and a large chunk of middle-income countries, this is a highly relevant discussion.
Right. No, I'm going to the audience now, otherwise they kill me. Go ahead.
May I ask you something? Because I'm missing something with this discussion. I know, and I wanted to ask you something because I'm missing something in this discussion. I know, I forgot who did the research to it, but there is research about how people feel good about their salaries in comparison to how other people feel about their salaries. And if you talk about people driving taxis in America because they don't feel they get as much money as they deserve for doing what they want, but I can imagine that people in countries that are in lower income, that it still can, lower income still can be rewarding. So maybe it's two things together. Maybe one of the part of the problem is there are people, they feel they don't get what they deserve. And for those people, just like with the little test with the extra dollars, then it's an incentive to do your best. But for people, they feel already they get what they want. They need the extra support in what their need to perform the jobs. So do you understand what I mean?
I think so, but I don't want to talk today about absolute income. The question of absolute income, very different question, right? At what income do people decide to leave a country, for example, right? The question about pay for performance is slightly different. It says, I'm going to give you 1,000 euros a month, and now the question is, should I give you all of it and saying you have a job, or should I give you half of it for sure and half of it depending on your outcome? So the focus of this discussion is to say, if we have an amount of money to give, the question is how we're dividing it. The question of should we add more money to healthcare and pay people better, it's a very good discussion, but that's not what we're talking about right now. So right now the question is, if we're going to get people to get to a certain level of income, how do we want to do it? Do we want to say, here's your income? Or do we want to say, here's 70% of it and you'll have to prove to us for the other 30%. And that's really the essence of the question. What quality improvement do we get when we make it contingent on something, show up, write the right prescription, have patients live longer, versus how much quality do we get when we say, we trust you to use your facility in the best possible way, and we'll, if things don't work out, we'll fire you, but we're not going to measure you on a daily basis or weekly basis and make this so contingent on specific things.
Thank you so much. I was just a bit curious. By the way, I'm from Nigeria, and I was very involved in the program in Kwara. What we found is that there's a bit of distinction between the public and the private sector healthcare providers and where pay for performance works. But I was a bit curious in the impact evaluation whether it was focused on the public sector, because really you can say in the private sector, if you don't do your work, you get fired, right? Or there is some measurement with performance. But in the public sector, really, it's difficult to fire people when you're not doing your work, because really the governance and all that. So I was a bit, curious about the impact evaluation, how if there was a focus on private sector, also private sector delivering more of the healthcare in low-income countries, the issue of systems and sustainability of the systems. Does the P4P, somehow linked to systems development or system strengthening in the public sector, and how we can apply that? So I don't know, if you can maybe elaborate a bit more on that distinction.
I can quickly answer on the results I've shown. So the majority of these schemes are in the public sector. In some of the impact evaluation, for example, the Cameroon one, a subset of the facilities were private, but the majority is in the public. And you're right about this point, this thing of you can lose your job. In theory, it's true. In practice, we find in many countries that people that don't show up for work, that don't perform well, or don't show up for work in their public practice, but show up in their private practice, keep their position and their salary. And so this issue of you might be fired in many countries is you need to try to work very hard to be fired, I guess. Or I mean, you got my point.
By the way, I like the incentives of being fired, not because it's so big, but because I think it's the right length. So if you think about pay for performance, it's often, or pay for service, it defines a very narrow window, right? So pay for service is you get paid what you do now. Pay for performance, maybe it's what's happening over a week or a month. The kind of payment we want is more holistic and over long term. So I like this idea of saying what you get is to get overall evaluation, because it just changes the window of how people view themselves, right? So if I'm a physician and I want to change something with the patients, and I need to change something that will show up in a month, in the US there's now a request, a proposal to pay hospitals based on how happy patients are when they leave the hospital, right? You just give them a little bit of MDMA before they leave, and that you solve that issue. And what you really want is especially in medicine, you want the long-term perspective. So I like keeping your job, but even other schemes I think would be better off if they were more holistic and more long-term rather than short-term.
Other questions?
Yes, it seems that pay for performance here is narrowed down to paying people or health workers for their performance. But I understood from the introduction that pay for performance is more than that, and it also can be incentives at facility level, allowing facilities to decide where to invest that extra money, because I think a lot of the intrinsic motivation comes from having the tools available to do your job. So could you say something about those elements of these pay for performance schemes?
So actually, maybe when we simplify the discussion when we say, oh, you pay the doctor, but in practice, all these bonuses that have come to the facility, and then there is not a formula, there are regulations of how much stays with the facility and then how they divide, and there is actually a discussion and at the facility level on how the part that can go in their pocket, how it's going to be divided. As you can imagine, it's easier to have that discussion in a small facility when there is one doctor, 3 nurses, and 1 midwife than in a regional hospital with 200 staff. So, and this is sort of in what we analyze in the result, I have to admit, it's sort of a black box. We don't really understand well. The incentives, you're right, are at the facility level, and part of it is used to not to put in the people's pocket, but sometimes it's buying equipment, but sometimes I've seen in Argentina, it's just we had nowhere to, the staff said we had nowhere to just relax between patients, and we just equip this room with a TV and with a coffee machine, and that's what we did with the money we received. So,
yeah. One more comment on this. This was so the No Child Left Behind policy in the U.S. For education gave some schools goals that were unachievable. Like the amount of improvement, like schools would have to improve by 1 standard deviation in a year. Completely unachievable. And what they showed was tremendous amount of cheating. So what happened is that the teachers would change the results on the exams for the kids. They will take the exam and they will cheat. And they would not do it for themselves, but they would do it for the group, because there was the group incentive. So I'm not saying that it's a bad idea to do it. I think it could be a much more powerful idea. But being more powerful, we have to recognize is a two-edged sword. Is more motivating to start with, but also create higher desire for gaming the system, because all of a sudden you're not just doing it for yourself, you're doing it for the whole group.
Dan mentioned several things about objections against pay for performance, like you start to maybe prescribe on the things that are incentivized, and you got to underwork, do less work on the things that are not incentivized. If you stop the incentive scheme, it's even going to be worse off than when you started. Did you include, this is a question to Damien, whether these kind of possible objections were sort of tested in the impact evaluations that you have been conducting?
So the 2 points that you raised, I'm not saying we are testing it everywhere, but so I mentioned, for example, in Zimbabwe, they've been very careful about the non-incentivized services, and they found both that the quantity and quality did not decrease. So that was a worry. But then I'll give 2 examples from Argentina. One that goes in your direction. If you remember, I said, okay, the ANC antenatal care visit increased for the beneficiary of the insurance, but there was a negative spillover on the population that was not beneficiary. So that's one example. But on the other hand, in this sub-study in Argentina, the question about discontinuing the incentive, at least in that study, they found sustained effect even after they discontinued the study. So the incentive. So yes, when we can, we are trying to look at these questions. The question of the discontinuing the incentive, you remember, it's an early set of results. We will need even more time to look at that.
Good morning. Very interesting discussion. I have a question to gentlemen from the World Bank. In light of Dan's elaboration that it actually doesn't pay off giving an incentive to the highest performance, we work very closely with the BRN initiative in Tanzania, where there's a large-scale project going on where healthcare providers that score better on quality get a higher incentive after a certain amount of time. And I'm just wondering, in light of the discussion that we're having this morning, should we actually change that work there and at least have an impact study arm where the lowest performing healthcare providers are incentivized?
I mean, I think it's probably true that both in the studies that Damien was presenting and the broader literature that we were presenting, we don't know enough right now, we may never know enough about the design of the incentive schemes. So, there are, in the developed world, vast differences across countries in the way the schemes are designed. Is it a continuous improvement? Do you have to reach a threshold, or are there multiple thresholds? Do you actually explicitly incentivize only the very top, the winners, ex post, or those who are down at the bottom ex ante? So we don't know the details, but it seems to me, and I take Dan's point, but I think basically the way I would read the literature and the effects that we are finding in that meta-analysis is pay for performance does work, that we're finding effects, not across all the indicators, not in all the studies, but we're seeing effects. So what does that mean in terms of the hypothesis about intrinsic and extrinsic motivation? I think it means that, yes, there may be some reduction in intrinsic motivation. It's possible. And if there is, it's not big enough to offset the added effect of the power of the extrinsic motivation. Otherwise, we wouldn't see positive effects. In other words, what we're seeing is a move from your salary gets paid or your facility gets a budget, irrespective of what you do, to a mixed payment mechanism that blends that with some payment, not a huge payment, but some payment, depending on what you actually do and what you achieve. Doing that produces results, not across the board, but it does produce results. If it's dampening intrinsic motivation, I think the question we should be asking is, how can we, from a policy point of view, the question would then be, can we reduce the dampening effect on intrinsic motivation, perhaps by combining pay for performance with some measures to make it clear we're not treating people like machines, that we do value their contributions. Sometimes people actually say, when you talk to them in countries, that actually they like this because it's recognizing their performance. Somebody at last is sitting up and taking notice of the fact that they're doing a good job. So it's not obvious to me that intrinsic motivation is being undermined, but from a scientific perspective, I think we would want to see more of what Damien was talking about in relation to Menno's question, is what happens when we discontinue these pay-for-performance elements? Do we actually see performance going back to its previous level, or, which would be evidence consistent with what Dan is saying, does it actually go down compared to what we started with? That would be evidence, it seems to me, of a dampening effect on intrinsic motivation. I don't think we see that in the health field, but it's true we don't have enough studies like the one that Damien was talking about.
Let me react to this in two ways. The first thing is that I'm hoping that when we move forward to think about incentives, we will start by really asking the questions of what's holding people back, right? If you think about your study and you say, let's just think about those people. What's holding them back? Again, knowledge, lack of interest, no ability to move, to get transportation. What is it? And it seems so blunt to just say pay for performance when you don't understand what the underlying cause is. So when you look at the meta-analysis, of course, you can't do that. But when you're dealing with a particular situation, I would love for you to start by saying, let's study a little bit about why those people are not performing, and then design the treatment for that. That's the first thing. The second thing about, do we see dampening? So if you pay people and you see an absolute reduction, there's no question you eliminated more intrinsic motivation and you got extrinsic motivation. But when you see an improvement of 3%, you have to ask your question of how much is this 3% an increase from extrinsic and how much is reduction from intrinsic. Mm-hmm. So the study I showed you at Intel, if we only looked at that day when we give the incentive, it would look that money is working well, actually almost as well as pizza and compliment. Where you saw the dampening was on the next day. In the same way that what we could do, I think that was your question too, is we could say, if we incentivize prenatal care, right, maybe we see the improvement there, but all of a sudden we see reduction in other things, that the intrinsic motivation, like, a pregnant woman is coming from something that is not prenatal care, and you've decreased motivation there. I mean, part of the problem is we have to recognize kind of this complete and incomplete model. Medicine is just too big. We just can't measure everything. Every study is measuring 1, 2, 5 outcomes. Physicians have to do, people in the medical system have to do so many things. Are we able to even detect where the intrinsic motivation goes down? Studies are not designed for that.
Thank you.
about incentives. In the Netherlands, the Dutch GPs got for their information system incentives to fill in better, and ICPC, the final diagnosis, to fill that better in, and the incentive was given by the insurances. After 5 years, the incentive stopped, but the CPCDs were filled in perfectly and are still filled in perfectly.
Yep.
And I think it's also because the feedback that you could get from your own system, that you knew exactly what diagnoses were run or what treatments were given. I think that could work also for Africa, but I don't know if you want to give that incentive per physician or per clinic, because I think the whole group of physicians should do it, otherwise it doesn't work.
Yeah, so this is an important question about what behaviors are habit creating and what not. So imagine a time axis and imagine how painful or unpainful an activity is. There are some things like reading. Like nobody enjoys learning how to read. It's an unpleasant process, and at some point it gets better and better, and at some point you learn how to enjoy it. There are some things like running. Some people say you run for 6 weeks and then it stops being unpleasant. I haven't found that personally, but you know, some people say it. But when we think about incentivizing, we can't ignore the question of what is the habitual nature of that activity. And again, like saying, like taking prescription on an electronic system, we can't say everything is like that. There are some things that are always going to be painful and you'll always prefer to do something else, like not eating these little Dutch cookies that you get with the coffee, right? It's tempting every day. If you want people not to eat them, you have to incentivize them for life. But there are some things that you can think about what are the initial steps that you do that just would get people to a habit, and maybe the healthcare system is like that. But the more general point is that I don't think it's right to think about medicine. There's just so many different activities, and we do need to think about them separately.
Okay. Last year, the OECD, they made a study on how to pay for healthcare, and they placed pay for performance in a continuum between fee-for-service, bundled care, and population-based payments. And I work at a health insurance company. I design overall contracting strategy, and I recognize what you say is that there are thousands and thousands of pay-for-performance models, and we are leaving it, we're stopping with it. Because we see the waterbed effect, that if you push on one point where it is affected, the water comes up at the other side. What I learned from the discussion is that we do this project on bundled payment, that they are exactly on what you say, they are holistic, they are long-term, and they are incomplete. Because they give healthcare professions a lot of freedom on what the issue is for their population, how they're going to solve it. We have a lot of technical issues implementing them, but what is your view on that? Because we see that pay for performance, it helps on some points, but overall healthcare costs still go up. If you look on the average for an insured member, is bundled payment really the way forward, or is it something we get disappointed also at after 10 years? I don't know, because it's my daily work and I have to defend all the time we put in it.
All right, we'll be back in 10 years.
I think that a system that is built on a complex system, if you start with a system that is complex and you build on autonomy and trust, you're going to get better results than taking a complex system and try to make a recipe, complete contract out of it. It's not that you're not going to have failures, right, as well. But look, how many people go to become physicians because they've made the cost-benefit analysis that it will maximize their lifetime income? This is not a calculation people make. People go to achieve a particular goal. And then what you do is, rather than play on that goal and their mission of life and their identity and so on, you create systems that basically undermine it. I would much prefer a system that builds on identity, reputation, pride, autonomy on average.
Go ahead. Just want, in general, I think we should be careful with comparing what's happening in OECD countries with developing countries. Because I think, as you said, the PBF design in your case was designed to control costs, and the issue was overconsumption. In the countries where we are doing this, the issue is underutilization. And so for maybe one more generation, we're just happy increasing consumption. And then at some point we should think, and maybe we should already think, no, about at some point there will be excesses. But in many countries, it's just, so it's a very different situation.
And I suppose, I mean, it links a little bit to one of the questions from earlier about the difference between fee for service and pay for performance, right? So, you know, so one dimension is, what is it you're paying for? Are you paying for procedures, or are you paying for some measure of quality of care? And presumably, part of the reason for going to pay for performance, as in pay for quality, is you're not trying to necessarily reduce costs, but you're trying to get a better health impact from the outlay you're getting. So, you know, I'd be curious if you've done the analysis to see whether, even if costs weren't going down, some measures of health were going up. And then you know, the other question, I guess, is the sort of thickness of the bundling process. You know, how many things are you bundling together? And that's, you know, that's where I suppose the risk with a highly fragmented pay for performance system comes in. If there are lots of different indicators, lots of different targets, people are chasing the ones that are easiest to hit and just forgetting everything else and perhaps reducing their effort on those other things. That's where you get all of these sorts of problems that Dan is talking about. The attraction of a sort of more bundled system is that you can avoid that. But bundling could be applied both to fee for service, where you're sort of talking about, say, paying, you know, like in the US, where you sort of move to, you know, for fee for service per lots of different items to, say, a DRG type system. But the same principles could be applied to paying for quality, where you're bundling lots of different quality indicators together in some sort of holistic approach to quality improvement. And there I think it's a trade-off, as in all of these things, because you're reducing the sharpness of the incentives, but you're reducing also the extent of gaming and also the extent to which people will be tempted to underinvest in activities where you don't quite get the payment right. So, and that's the challenge. In the very finely graduated systems, you've got to get the link between the payment and the cost exactly right to avoid these sorts of gaming problems and underinvesting problems. And that's an attraction of the bundling approach.
Here's an experiment I would love to run. Maybe you could do it in Holland, we could do it in Kenya. You take a clinic and you basically give no constraints to the physicians. You say, we'll take all the payment that you could get from all the things. We're just increasing everybody's salary. You're not dependent on quality. We're not measuring you. There's no paperwork. You don't have to submit anything. And then you evaluate their performance. You say, we trust you. We just trust you to do this well. And I want to see what this clinic will do at the end of the year. My guess from Duke, I teach at Duke, I know this is the healthcare system I know. If you promise physicians to take away their paperwork and their feeling of, you know, how much they have to fill and being reported and being tracked, just the amount of time, energy, attention you would free would get them to view the whole profession very differently.
There is some, if I may myself, there is some parallel here. You showed a lot of projects on conditional cash transfer, but there's quite a bit of evidence that non-conditional cash transfers also do a lot of good. And this sounds like a non-conditional cash transfer.
Yep.
And it's maybe worth trying. Yeah? So.
But that's a budget. It's a salary, isn't it?
Right.
Yeah.
Somebody snuck a microphone in there, so that was smart of you. Go ahead.
Okay. Thank you. I'm Peter Risha from Tanzania. My observation is that most of these P4Ps impact evaluation, the design is short-term, hoping that if the results are good, the governments can integrate this in their budget if the economy allows. But this is not always the case. So in this case, you should think very much about the dampening effect, because you are removing the incentive. Even if it worked, you are removing the incentive maybe in 3 years' time. But you are already maybe done damage, like you are distorting the market, where most of these P4P are implemented in public. So for a short period of time, you are giving incentive to the public facilities. So in this case, the private do not have time to grow. But also within the implementation in public facilities, you are leading in a vertical intervention, ANC, delivery. So what happens to the other departments? The motivation of staff. So these are the things maybe not to be evaluated not at end line, but maybe a few years later, what happened?
So maybe I can try to answer that, probably not completely, but in a way it's short-term, but some people think our impact evaluations take too long. What is typically done in this project, so first they will take one district, let's say in Tanzania, and they'll just test run the system, the payment, and it's not part of the impact evaluation. Then they'll take a few health districts and do the impact evaluation where there will be a control group. But it's not yet the whole country. That's going to take 2 or 3 years. And then based on these results, hopefully, sometimes they make the decision before the results are there, but they will decide whether they'll scale up to the entire country and which, if we are testing different model, which model are they taking, or are they taking. So that's, in theory, the sort of timeline that we are trying to have. And in some countries, it's true that, there was enough money from the country, from the government, and from the donors to scale up fully. In some, that was not the case. So that's a little bit depending, on, as you said, on circumstances. But that's sort of the timeline we are trying to get.
Can I just add one quick point, Joe? So in a way, I think the way to think about these experiments is really what's the appropriate mix between budgets and salaries on the one hand and performance-related payments on the other. And that's a separate question from how much should the health sector be spending. Now, to get these experiments going, it's true that they've often been accompanied by extra resources for the health sector, but it's perfectly possible that the government might say at the end of the experiment, we can't keep this extra level of resources going, but now we know we shouldn't be relying exclusively on budgets and salaries. So we change the mix of payments, we go for a blended payment system, as most OECD countries have gone for many years, and we have to unfortunately scale back the level of spending overall. But these are two separate questions.
Okay, we have 4 minutes. Can I see a show of hands on who still has burning questions? Okay, if you keep your questions short and your answers precise, then we can do those two.
Yeah, I don't know. I'm sitting on the fence when it comes to pay for performance, because if you've said it clearly with the US, the problems that they were facing, which led to the introduction of P4P, are actually problems that you couldn't solve with P4P. But if you look at Ghana, you have these doctors, they work for the government, and then they go to they also, in the evening or something like that, go to the private facility and work for more money. And there you see that they are really motivated to do the job, that they stay there for a long time and they don't want to even, sometimes, they go home too late or whatever. When they go to the public sector, their motivation is down. Yeah. And you'll be tempted to think that money is not the issue, but when they go to the private sector, they pay very well. So I just don't know where you have to strike the balance between incentivizing, but also, of course, doing something about the overall performance management of these people.
when you have people experiencing two systems, it's like people are within subject design, people become incredibly sensitive to small differences, right? So if you listen to two speakers, one next to each other, you will become incredibly sensitive to small difference in quality. If you had one or the other, you might never be able to tell the difference. So a mix of private and public can make people incredibly sensitive to variable, much more than you would predict from a between country perspective. That's one thing. And the second thing is that money is very measurable. So if you think about, money life has lots of attributes, how much freedom you have in flexibility and impact and so on. Money is the one dimension that has decimals. And because of that, it does get more of our attention for good and for bad. So this is why pay for performance, by paying people very small amounts of money, you can redirect a lot what they're doing, because it really redirects attention in a very serious way. And I think systems that allow people to practice both have very little chance to being useful, right? So if you ask me what would I do in those systems, I would try to figure out how to merge them, do something with them. But the moment you have people living in these two systems, it can't be good.
Last question was there. Yep.
If you want to do pay for performance, you have to measure and you have to communicate, right? So you could even do the measurement and communication without doing the payment. So I was wondering, I think this is a question to Adam in the first place. Have you looked at studies that compare just the measurement and the communication of performance versus a system that does that plus the payment? Because in principle, that would be sort of a horse race between intrinsic and more extrinsic.
So not in the meta-analysis, but Damien, I think, can speak to the World Bank studies.
So one of the study that I mentioned, the one in Cameroon, is not exactly what but one of the intervention arm was reinforced supervision only, which included measuring and communicating. And we didn't find that was very, had a lot of impact compared to the two other groups that had some impacts, which were the PBF and the just additional budget. So.
Okay, I'm afraid time is up. I'd like to give the speakers 1 minute each if they have a final word of wisdom to share with us.
I don't do well under pressure.
I'll pay you. I'll pay you a brick. Yeah.
I think for me, the discussion is really about trying to figure out what is holding people back, and what is the right solution per challenge that is likely to help people out, and without a deep analysis of why people don't perform to the best of their ability or this, I think pay for performance is just going to be, pay for whatever is just going to be wasteful. But if we target it exactly, then there might be some potential for this field.
So Dan asked earlier whether we would all like to have our pay linked to our performance. I didn't put my hand up because we already do in the World Bank. And in the research group, we actually have quite an elaborate system of counting things like articles, citations, downloads, and stuff like that. But it's the manager at the end of the day that gets to make the recommendation on the salary increase. And we have this sort of elaborate regression between the manager's recommendation and the objective data. And all our discussion is on unobservables, being economists. So the manager who's recommending a salary increase above the predicted from the regression has to make the case. And that's something that's not coming out in these pay for performance. There's nobody saying, actually, on the objective data, it doesn't look like this facility should be receiving that much more. But actually, we have some unobservable information here that makes us want to put it in higher performance. Now, do people like it? It turns out that the research group in the World Bank has a much higher estimation of managers linking their pay recommendations to their performance than the rest of the institution does. And in fact, now we're kind of being asked, how do we do that? How do we achieve such high satisfaction on the staff engagement surveys in respect of pay for performance?
The supervisor gets to see your responses, and they get to decide your salary.
Damien, last word.
Speaking of high pressure, it's Adam who is deciding about my salary increase.
You're doing fine, Damien. That's great.
So, maybe just what I hope we convey is that there is this large effort at the World Bank to push for pay for performance, but it doesn't go without serious evaluation and without trying to challenge the consensus that that it should always work and testing different models and we would love to find the opportunity, for example, to compare a classic PBF with something working more on intrinsic motivation.
Can I say one thing? So I used to teach at MIT, and they had a very elaborate system to what teaching means. There was an equation, and the equation had to do with how many students are in the class and how many hours they work. And there was a lovely equation, and we had to get 112 points a year. So I was at MIT for 10 years. In total, across the 10 years, I taught 7 times. 7 semesters, 1 class. And it's because I could optimize that equation. But I actually love teaching. It will be good for me to teach. It's good for the students. But they gave me an incentive system that says, to prove that you're smart, which is what everybody else is trying to do, you have to teach the least amount possible because this is the equation. And I got to teach very little. And it's that system completely redirected all my effort. When I was there, I was obsessed with optimizing that system rather than more generally optimizing my time, which is good for me, the students, the institution, and so on.
All right, you're probably not the only one who can optimize an equation at MIT, but
that's right.
I'd like a hand of applause for the people behind the scenes. Thank you. Thank you for making this work so smoothly. And here's Michael with a footword.
Yeah. No, Damien, Adam, Dan, and Jacques, thank you. I don't do any closing words. I just wanted to say that now that you understood, I think that you will not be paid for the questions. We have a complete unconditional lunch for everybody. Okay, thank you very much.
Good.